Good evening, all. Today it's a feast for us. We are having today the webinar on risk of cardio-renal metabolic complications. Along with that, we have severe asthma management. So we have many stalwarts today for our this program. So I think better I escape that, and I will just start with our further programs. So on 3rd April, before starting our program, I'll be telling you about our further programs. So one of the program is on 3rd of April. There is an installation ceremony of our incoming president, Dr. Meenakshi Deshpande, and team IMA Pune 2022-23. And the chief guest will be Dr. Padma Bhushan Dr. K.H. Sancheti. And a guest of honor will be Mr. Vikram Kumar, IS from Commissioner IMA Pune. So the our moderator and coordinator with Dr. Suhas Ardas, Director of Cardiology, Sahyadri Hospitals will be there. And there are many cardiologists, along with that endocrinologists and hepatologists and nephrologists too. So it's a full day webinar. Plus you can attend it physically also. So it's a hybrid. So you can attend that program and get 2 MMC points for this program. Then another program is it is a diabetic course. So I think all of you must be aware of that, and about 130 registrations we have got for this diabetic course, and it is of 12 modules course with an exit exam, and it will start from 9th of April every Saturday from 2 p.m. to 5 p.m. with 12 MMC points. So every module is designed in such a way that different aspects of evidence-based medicine, diabetes will be discussed, and more than almost 130 people who have joined there from various parts of Maharashtra and India. They are already enrolled for this. So I think this 130 is quite a good number. So now we are not taking any further registrations. In case you are interested, you can contact us. We will think over it. So we have another program on 17th April. So we will announce the particulars of the program later on. So now with this, I will hand over the mic to our president, Dr. B.L. Deshmukh. I am Dr. Alka Kshirsagar. I am secretary of IMA Pune now. And Dr. B.L. Deshmukh, sir, he is the president. So he will give presidential address. So over to sir.
Good evening, everyone. I welcome you all for this webinar on risk of cardio-renal metabolic complication along with the severe asthma. For this, we have eminent speakers in respective field like a respiratory system, kidney diseases, cardiologist, diabetologist. Moderator will be well-known cardiologist from Ruby Hall Clinic, Dr. Sunil Sathe. Without wasting our time, I hand over mic to our secretary, Dr. Alka Kshirsagar.
Thank you, sir. Now I will request Mr. Nagendra Naik, area manager from Mumbai, AstraZeneca, to moderate further session. So, Mr. Nagendra.
Thank you very much, IMA Pune, for giving the opportunity to AstraZeneca for the scientific dissemination and the benefit of the healthcare professionals over here. So I request, I take this opportunity to introduce the eminent speaker for the today's the session on the severe and uncontrolled asthma. Nimesh, my slides are visible?
No,
no. Yeah, now it's
please share the screen. Yes, now it is visible.
Dr. Bharatwal sir join?
No, not yet.
Dr. Bharatwal, are you there?
I think I need to check.
Is not yet joined?
Nimesh, can you check with Jishan?
No. Yeah, sure.
Yes,
You
there are.
continue.
So today we have two pulmonologists, Dr. Barthawal sir and Dr. Lakshmikant Yenge sir. So both of them are pulmonologists, and Dr. Barthawal sir, he's just joining. So by the time I'll take this opportunity to tell you the topics which we are discussing. So first topic is by Dr. M.S. Barthawal, uncontrolled asthma with frequent exacerbation, GINA-based treatment. And another topic, second topic by Dr. Lakshmikant Yenge. Again, he's a pulmonologist and he'll be speaking on advances in severe asthma management with biologics. So I think if Dr. Barthawal has not joined, can we request Dr. Lakshmikant Yenge to join? Is he joined? Mr. Nagendra?
Yeah, ma'am. Dr. Bharatwal is there.
He is joined?
Jishan, can you confirm?
Not yet.
He's busy. All busy cardiologist and pulmonologist now.
Dr. Yenge is there. Jishan,
Dr. Yenge has not joined. I don't think so.
Just give us 2 minute time, I think.
He's taking time.
Ma'am, actually, yeah, but the what time they have got is 6 p.m. actually. So I think by
just 2 minutes to go.
6 p.m. they will join.
Yeah, sir is joining. Nagendra, sir is joining.
Yeah, sir has joined.
Yes, sir. Welcome, sir, and good evening, sir. I'm Dr. Cicada from IMA Pune. I am a secretary of IMA Pune, and Dr. B.L. Deshmukh is a president. So we are just welcome people. So we can tell. I think I'll request Mr. Nagendra.
Yeah, ma'am. Very good evening to all.
From Mumbai, AstraZeneca, to introduce Dr. M.S. Barthawal, sir.
Yeah, very good evening all the audience and healthcare professionals which are joined on the this forum, and thank you very much, the IMA Pune, for giving us opportunity for the benefit of the scientific dissemination of the HCP. Let me welcome the eminent speaker for the today's talk on the management of asthma and the guidelines of GINA, as well as the difficult to treat asthma, the topic of Dr. M.S. Bharatwal, the well-known face in the vicinity of Pune in the field of pulmonary medicine. Dr. M.S. Bharatwal. Sir has DM pulmonary medicine and more than 39 years of experience, out of which 25 years as a specialist. Well-known face from AICTS Pune and HOD of D.Y. Patil Medical College, Pune, Pimpri Chinchwad. Dr. Bharatwal has done his MD medicine from Armed Forces Medical College, Pune, and DM in pulmonary medicine from the prestigious institute, Postgraduate Institute of Medical Education Research, Chandigarh, known as PGI Chandigarh. Dr. Bharatwal has also confirmed with the Fellowship of National College of Chest Physicians of India and Fellowship of Indian College of Physicians. He worked in the referral respiratory centers in armed forces and medical services. He has 26 years of rich experience and expertise in management of disease and related to the pulmonary medicine. He has published more than 80 research papers in leading journals with the focus of the research in the field of asthma, COPD, and pleural diseases. He has been a speaker at all national conferences of pulmonary medicine, in the regional conferences, as well as a postgraduate seminar for more than 15 years. So over to you, Dr. Bharatwal.
Thank you, Nagendra, and my good evening to all the IMA organizers, and thanks to them for giving me this opportunity to speak on this topic. Am I audible?
Yes, sir. Dr. Yenge has also joined. So welcome, Dr. Lakshmikant Yenge.
Yeah.
Yes, join.
Yeah. Lakshmikant, hello. How are you?
Thank you, ma'am. Thank you, ma'am. Hello, sir.
Hello.
Good evening.
So I think without wasting any good evening to all the IMA organizers.
Thank you,
And
sir.
again, once again, thanks for giving me this opportunity. I am quite happy to see that in the beginning of this conference, there are 80 participants. So I only hope that these participants stay, during this whole webinar and listen to the eminent speakers. Apart from me, there are so many eminent speakers, and I hope they don't log out and all. Most of them what they do is they log in, they switch off their video, and they start doing something else. So request to all of them to keep their videos on so that the speakers get motivation to speak about their topic in a very confident manner. So may I request the chairperson to allow me to share the screen? May I share my screen, please?
Yes, sir.
Okay. What's happening? Just give me a minute. What's happening?
Piyush? Piyush, please help, sir. Sir,
Just a minute. No,
what's the problem?
Just a minute. Just a minute. Just give
Okay.
me a minute, please.
Yeah, okay, okay.
Something is wrong. I don't know. Nagendar? Hello?
Yeah, can you? Yeah. I'm hearing you, sir. Can you mail me otherwise, right?
Just a minute. Just a minute. Oh, no.
Hi, sir. Mimesh here from Astra. Sir, have you saved this file on your desktop, sir?
Yeah, I have shared it on desktop. Just a minute.
Okay. Because we can see that you have started sharing the screen, but after that it is not coming.
Yeah, so I have just shared it on my desktop. It is on my desktop.
Right, sir.
Can you help, sir?
Just a minute. Just a minute.
So down there is a green.
Yeah, I know it. I know it.
Started that share screen. Yeah, but
Yes,
now the
Yeah, we can
yes,
see. Yes.
sir, good.
No,
Now
no, this is Lakshmikant's.
oh, it is Lakshmikant, sir.
Checking whether I can share or not. So it is okay, can share.
What is happening to this thing? I don't know.
Yes, sure. Screen is sharing, but the slides are not visible.
I am sharing from a Mac. I don't know. This Mac actually gives me sometimes problem actually. I don't know. I think what we can do is, Nagendar,
Yes, sir. I will start sharing. Let me.
Yeah, he's got this slide, so no problem then.
So you stop sharing. You click the first button to stop share.
okay.
The screen is.
No, Nagendra, same happened with you also, I think.
Haven't?
No. Yeah. Yes.
Got it. Thank you.
Yes, sir.
I think you do the full screen.
Yeah, it is
Slide.
a full screen.
Slide.
Yeah, full screen only, sir.
It's full screen.
Yeah, full screen, sir.
Yeah. Okay. Done. Anyway. Sorry for this technical glitch. I think something wrong with my book settings. So.
It's okay. You can start, sir. We can see it now.
Yeah. Okay.
90
Anyway,
people. So between 10 more people are joined. So now there are now 90 people.
I hope these 90 people they remain glued onto their TV or their computer. They will just log in and push off. Anyway, so my topic today is actually the topic given on this was something like, difficult to treat asthma and how do you treat uncontrolled asthma using the GINA guidelines approach. So I have changed it a little bit and I'm going to give it's based on the GINA guidelines only. But it is a practical approach, because we in India, we have to tweak these guidelines so that we can have a practical approach for our country, because management practices differ from country to country. It depends on the resources, the kind of patients we have. So I'm going to tell you about this practical management approach of difficult to treat asthma and that uncontrolled asthma. Next slide, please. Yeah, the next slide, please. Agender.
Yes.
Next slide. Yeah.
I am on the next one.
Yeah. Okay.
Moving little slow.
Yeah, it's okay now.
Yes, sir.
Yeah, so see, in spite of so many advances in the pharmacotherapy, in the inhalation devices, and many international, national guidelines, and in spite of holding so many seminars, conferences, webinars on asthma, but the sad story is that the asthma control remains suboptimal most of the time. And this talk, I hope that most of the participants in this webinar are physicians and also maybe some chest physicians. So this basically is focused for physicians and general practitioners. I'm sure that this webinar doesn't have too many chest physicians, and most of them are physicians and GPs. And because 95% of these asthma patients are initially managed by physicians, so it is of great importance that physicians and general practitioners should know how to manage asthma properly. Next slide, please. So this is the story of poor asthma control in India. This is a study by Dr. Salvi. This is Asthma Insights and Management in India. And what it revealed, it revealed a lot of startling facts, that 91% of the asthmatics in India, they thought that their asthma is under control. But when asthma was assessed using objective measures, none of the asthmatics had controlled asthma. It is very startling and shocking. Another shocking fact was, which came out of this study, was that 75% of asthmatics have never had a lung function test. And almost 90% of the asthmatics reported an average use of oral steroids almost 10 times a year. Very, very, very startling fact. Next slide, please. And only 36% of the patients, they used controller therapy and 50% use rescue therapy. So use of inhalation therapy also much less amongst the asthma patients in this country. Now, we also have done studies. I've been doing it since 2005. We published in JAPI, and this also showed, actually this study was done in patients from armed forces, and this also showed that we have a suboptimal control of asthma patients. So, and also in 2013, we conducted a study amongst general practitioners and physicians in and around Pune city. We wanted to find out how do they manage their asthma. And we found that asthma management was very poor. It was suboptimal. And this is from my clinic. It's a tertiary clinic. It is not published as yet. Till last year, I had seen around 380 patients. Out of that, 340 patients were adults and 40 patients were pediatric. And they all had come to me because of uncontrolled asthma or severe asthma. And you see the initially 320 patients out of these 380 patients, 320 patients were seen by physicians, and only 12% were seen by chest physicians and 9% by GPs. So as I mentioned earlier, most of the asthma patients are seen by physicians, and chest physicians see very few of these patients. They see patients only when the asthma is uncontrolled or it becomes severe. Next slide, please. So as I mentioned, all these studies show that the asthma control is very, very poor. Now, the first and most important step is before we start treating these patients as uncontrolled asthma or severe asthma, it is very, very important to find out that to diagnose that is it really a difficult to treat asthma, because it may be a true difficult to treat asthma or false difficult to treat asthma. Why I'm saying false difficult to treat asthma is that asthma is being treated, but the treatment is not optimum. He's not been given adequate doses of steroids. He has not been taking his inhalation therapy properly. He has some comorbidities like OSA, he may be having COPD, which has not been looked into. There must be some environmental factors which have not been looked into. So after ruling out all these factors, the patient is getting optimum treatment from the physician, his inhalation technique is correct, and he's got no environmental factors which are affecting his control, only then we can say that this is true difficult to treat asthma or severe asthma. So it's very, very important. What happens most of the time, we do not look into these aspects, and a patient comes to the chest physician or physician, he starts thinking, oh, he has received so many doses, he has been on inhalers for so many times, so many years and all. So I think it is difficult to treat asthma, which is wrong. We have to find out which are these true difficult to treat asthma. Only then we will move ahead with the management strategies. Next. So this is how uncontrolled asthma is defined as. Now it has been given various terms, severe asthma, refractory asthma, steroid-resistant asthma. So in summary, basically uncontrolled asthma is, as I mentioned, that first of all, you have to rule out all other conditions which are leading to uncontrolled asthma. Whether he's getting a optimum therapy or he has been looked into, those environmental factors have been looked into. And after this, if the patient has got a poor symptom control, his asthma control test is less than 20, he's having frequent severe exacerbations, and he has to take 2 or more courses of systemic steroids in the previous year. If he's having serious exacerbations, means he has been hospitalized or he was in ICU for severe asthma, or he has got, if you do his pulmonary function test, and if his FEV1 is less than 80%, and his asthma starts becoming worse after you start tapering his high doses of inhaled corticosteroids or if he's been put on oral corticosteroids, and the moment you start tapering his oral corticosteroids, his asthma becomes severe. So this is how we define uncontrolled asthma or severe asthma. Next slide, please. So let's see the situations which lead to false difficult to control asthma. Now, as I mentioned before, difficult to control asthma, most of the time, I will say 85% of the time, it is false difficult to control asthma. So you have to ensure that it is not false difficult to control asthma, it is true difficult to control asthma. So what all we have to look into before we say that it is true difficult to control asthma? First of all, is it the correct diagnosis? Is it really asthma or is it COPD? Most of the time in our setup, we do not pay much attention in differentiating asthma and COPD, and sometimes it is difficult also to differentiate asthma from COPD. So he may not be having asthma at all. So you have to first confirm that patient has really got asthma undoubtedly. Then second thing is that is his therapy suboptimal? Third is he having diseases which mimic asthma? Then is environmental, as I mentioned before. Are there any environmental factors? Some factors may be there in his house, some indoor pollutions which are leading to uncontrolled asthma, or is there lack of asthma education? So we will go one by one all these factors and see how we can rule out all these conditions and then label the patient as having true difficult to control asthma. Next. Now, this is a very important study from a Canadian respiratory research workup, where they re-evaluated the diagnosis in adults with asthma. These patients were diagnosed by physician as asthma, and they were re-evaluated by experts. And the surprising finding was that a significant portion of these patients who were considered to have severe asthma did not have severe asthma or even asthma when they were carefully re-evaluated. So this is a very important thing, that you got to re-evaluate the patient and find out whether it is really a severe asthma or is it an asthma or some other obstructive airway disease. Next. Yeah, coming to the suboptimal therapy, the most important factor which leads to uncontrolled asthma is you are not using inhaled steroids optimally. There is a steroid phobia, not only among patients, but also among physicians. They are scared to use even inhaled steroids in optimum dosages. So this is a very, very important factor. The patient is given some dose of steroids and he is asked not to overuse it, or rather not to use it optimally. And also there is a trend of using these relievers like acetylene, levoacetylene, more frequently than your controller medications like inhaled steroids. So this leads to basically uncontrolled asthma. The second thing is incorrect use of inhalation devices. Now, this is a global problem. I think if you do a survey and you find out more than 70% of the patients do not take their inhalation devices with a proper technique, which is very, very important. If they do not use proper technique, there will not be an optimal deposition of drugs. So it is very, very important that this technique should be reevaluated, whether the right device has been given to the patient, is he able to use that device effectively, or whether this device is okay for him or not. If he's a 70 years old patient, he cannot be given a dry powder inhaler where he has to generate an optimal inspiratory flow. So this is very, very important, and most of the time this is one of the important causes of uncontrolled asthma. The last thing is that, no, previous slide, please. Yeah. So you ignore, because you see, almost 70 to 80% of asthma patients have allergic rhinitis, or rather allergic rhinosinusitis. It is not looked into because this is a united airway disease. As I mentioned, 80% of the asthmatics, they have rhinitis. So if you do not look into it, if you do not treat it, your asthma will not be cured. Second thing is, which is usually associated with asthmatic patients, is your GERD, which also most of the time it is not obvious. Patients may not give symptoms because 60% of the patient with GERD may not have symptoms. So it is very important to address these problems before we say that this is a difficult to control asthma. And last but not the least is, patients are not aware what optimal asthma control is. See, you give patient a therapy and you tell him, okay, you take these inhalers morning, evening and all, and he's happy. He's happy doing his routine things. If he's fond of jogging, he will stop jogging. If his office is on the 5th floor, he will not use stairs because he gets breathless. He uses lift. So his asthma is not under control. Control asthma is that you are not doing any lifestyle modifications. You can do whatever you want to do, physically, mentally, everything you are able to do when you have asthma. Only then you can say that your asthma control is optimal. My patients, I have some patients who have been doing a full marathon because they have been doing it for the last so many years. They could not do it because of their asthma not being under control. So this is very important for the physicians to understand what optimal asthma control is, and the same thing has to be conveyed to the patient so that he knows, yes, my asthma is under optimal control. Next, please. Next slide, please. Now, there are some diseases which mimic asthma. Previous slide, please. Yeah. So COPD, as I mentioned, it may sometimes difficult to differentiate, but it is very, very important because the management strategies are the course of the disease. The management strategies are different from asthma and COPD. Sometimes an old patient may be having CAD. He may be having a left ventricular failure. He may be having bronchiectasis. He may be having a foreign body, which is very important. You got to investigate him. You may have to do his bronchoscopy. Then there are some patients who have vocal cord dysfunction syndrome. Some patients have pulmonary embolism. They may present with asthma-like features. Patients of pulmonary eosinophilia, they also may have this asthma-like features. So these patients needs to be investigated with proper history. They have to be investigated with further investigations like 2D echo, HRCT of lungs. You got to do sometimes you got to do a bronchoscopy. Then you got to do sometimes his allergy testing, and also sometimes you got to do his diffusion studies and also bronchoprovocative test to see whether he has got asthma or not. Next slide, please. Again, a most neglected factor is environmental and occupational factors. We do not ask patient how is his indoor environment. Is he using any cotton stuff? How much dust is there? Because cotton pillows, cotton dust, upholstery in the house, pets in the house, some leakage in the house, seepage in the house. There are so many, these cockroaches in the kitchen and all. So all these factors need to be looked into. So it is not only giving inhalation therapy to the patients, but also looking into these details. Because if you do not obliterate or do not control these triggers, environmental triggers, indoor air pollution is much more common than the outdoor air pollution. So we got to look into these factors and find out, are there any environmental factors? And you got to control them also. Next slide, please. Now, lack of asthma education. I don't know how many physicians, even chest physicians, spend time with the patient and explain to him that what is asthma, what will be the course of this disease? Is it curable or can it be controlled? So it is very, very important that you got to educate the patient about the disease. You got to tell him about the use of inhaled corticosteroids. Then you got to explain to him what optimal asthma control is. Also, you have to give him a roadmap. You have to give him some kind of management plan, that if he's got acute exacerbation, if he cannot go to doctor, he's away from hospital or any clinic and all, then how can he manage his acute exacerbation at home? And also demonstrating, as I mentioned before, the correct technique of using inhalation devices. Next slide, please. Yeah, this is a study which we conducted in Armed Forces Medical College, and we wanted to see that how does this asthma education program affects asthma morbidity, inhalation technique, and asthma knowledge. And obviously there was a great impact on improvement of asthma morbidity, inhalation technique, and asthma knowledge if you spend time in giving patient optimal asthma education, which has to be done by doctor himself, or if he has trained some respiratory technicians or some counselors who have been trained well to give this kind of asthma education. Next. Next slide, please. So this slide sums up that how do you differentiate true difficult to control asthma from false difficult to control asthma. So only after you have ruled out that the diagnosis is correct, patient is not on suboptimal therapy, he doesn't have any diseases which mimic asthma, he doesn't have any environmental and occupational factors which are affecting the control of his asthma, and he has been given adequate asthma education. After you have ruled out these factors, only then you label him as true difficult to control asthma or uncontrolled asthma. And as I mentioned, the prevalence is maximum is 5 to 10%. So they constitute a very little portion of asthmatic patients. Next slide, please. Now, actually, I will not go into these details because Dr. Lakshmikant Inge, who is my younger colleague from PGI and very dynamic, I will call him very dynamic and professional colleague who is absolutely updated about his pulmonary medicine knowledge. So I will just mention that when you have a patient who is true difficult to control asthma, you know that he's really uncontrolled asthma, how do you work him up? So these days, actually in the beginning only, we phenotype the asthma patient because there are various asthma phenotypes and we must know this patient belongs to which phenotype. So the most common phenotype is eosinophilic airway inflammation, which we call basically allergic asthma, in which Ig levels are very high. It is early onset. You have blood eosinophil count, which is more than 300. If you do his pheno study, it is more than 20 parts per billion, and sputum eosinophil more than 2%. And then you have neutrophilic airway inflammation. You have mixed neutrophilic eosinophilic inflammation. Next slide, please. You have paucigranulocytic, you have hyperresponsive variable obstruction, and you have fixed obstruction. So you have to work up the patient and you have to find out which phenotype, because your therapies, which are alternative therapies, which are advanced therapies, these therapies will be used only when you correctly phenotype the patient, which is very, very important. You cannot blindly use the biological therapy or other therapies like bronchial thermoplasty, which I think Lakshmikant is going to speak about. So it's very important that you must phenotype the patients. Next. Next slide, please. Nagendra, next slide.
The slide is visible, sir?
Yeah, next slide. What happened? Okay.
Yeah, slide is visible, sir. I change to next.
Yeah, I changed to next. There is a
Getting,
Okay. Done.
now
So how do you now? Actually, these days we have biological therapy. I'm not going to talk about it because Dr. Lakshmikant Inge is going to talk about it. So biological therapy is available, though it is a costly therapy, but definitely a useful therapy if we use in patients who are carefully selected. So as I mentioned, first of all, you have to find out who is a real too difficult to treat asthma. Is he really a severe asthma or too difficult to treat asthma? Previous slide, please. Something is a lot of technical glitches.
Yes, sir. Maybe he's disconnected, sir. He'll join immediately, sir. Yeah, he has joined, sir. Nagendra, I think you need to reshare again.
How much time we have, madam?
Sir, it was up to 6:30 time. How much
I
more?
will take another 5 minutes, madam.
Okay, sir. Okay, sir. Because
Nagendra, kindly reshare.
others.
Nagendra, you got to reset it.
Already 35. It's already 6:35 because the next.
I'll just take another 5 minutes. Give me another 5 minutes, please.
I don't mind because the speakers are also there.
Nagendra, I think.
It's okay. I can finish off little shorter, 20 minutes or so. I can finish.
Okay, sir. Okay, sir. Okay, sir.
We can cover for that.
Yeah. Lakshmikant has been very generous. Thank you, Lakshmikant.
No, sir, no.
I think these are unusual technical glitches which I'm experiencing for the first time.
Sir, I think Nagendra still his audio is not enabled.
Nagendra, what happened?
I was also fearing that my internet cover is little shaky. I might face some problem.
My internet cover is also is okay, but I think something is my Mac settings. I don't know. I've been doing it with Mac only. I don't know what happened. Nagendra, are you audible? Nagendra?
Yeah, sir. He has just joined. I think his audio is not enabled actually.
Okay.
Yeah. Nagendra, can you hear us now?
Connection is a bit unstable actually. I will sharing this slide.
I think I'll stop my video. That is better, I think.
Yes, sir. Yes.
Are you sharing it?
Yes, sure. Yeah, screen is visible, sir.
Yeah. So I will not do those case studies. I will go into. Let me go. No, go next one. These are some few case studies. I will not talk about it. Next. Yeah.
Yeah.
Next. There are some cases. So, yeah. Please, the previous one. Yeah. So please. So what I mentioned before is the next one. Yeah. So physicians and general physicians need to hone their asthma management skills. Now, when we manage these difficult to control asthma, we have got two methods. One is we optimize the inhalation therapy or we give them biologicals. So how do we optimize the inhalation therapy? We can do it by using smart therapy or maintenance and reliever therapy. Next slide, please. Yeah, this is maintenance and reliever therapy. Now, this is a concept which has been recommended by GINA since 2006. And here what happens, you are using smart maintenance and reliever therapy in a single inhaler, which gives you anti-inflammatory effect also and bronchodilation also. And you got to take morning, evening, and also as required. Next slide, please. And this is the concept, if you use this therapy, instead of using, suppose you have an exacerbation, and if you use this maintenance and reliever therapy, instead of using your reliever therapy only in the beginning, so you avoid the exacerbations. And in the later stage, you may not have to use oral steroids. So this therapy is definitely much, much better than giving ICS, LABA and reliever separately. So this formoterol and budesonide combination is definitely much, much better than giving your salmeterol, fluticasone and a reliever this reliever therapy separately. Next slide, please. Next slide. Next. So there are so many studies. There are more than 6,000 patients have received this therapy, and all these trials, STEP, STAY, Cosmos, and all have shown that this maintenance and reliever therapy in a single inhaler is much, much better than giving ICS, LABA, and inhaler and reliever therapy separately. Next slide, please. Yeah, these are the various studies which show that you have a reduced rate of severe exacerbation with the combination of budesonide and formoterol when you use it in moderate to severe asthma. Next slide, please. Yeah, next. Yeah, all these studies, Cosmos, Champion, Eurosmart, Saccharin, they have all shown that if you use this therapy, maintenance and reliever, there is 40% exacerbation risk reduction. Then there is a prolonged time to first severe exacerbation with smart therapy. Next. So this is what the comparison, your exacerbations are reduced, your hospitalization are reduced, your oral corticosteroid courses is reduced when you use this maintenance and reliever therapy vis-a-vis your high dose ICS, LABA and reliever therapy separately. Next slide, please. So this is my last slide. Actually, it is basically very imperative on our part, especially on the part of physicians and GPs who have been managing asthma as a first line therapist. They need to definitely update themselves in the asthma management so that all asthmatics can breathe free. Not only breathe free, they can do whatever they want to do, any kind of physical activities or mental activities. Thank you so much. And once again, I'm very sorry for the technical glitches. It has happened for the first time, and there was a lot of, it was late starting, and in between there was slight transition change and all. I am sorry for that. Thank you so much.
Thank you, sir, for your very nice lecture on difficult. It's not a difficult asthma, but it is difficult to treat. So really, it's a challenge to all of you. But I think there are many medicine available now. So people are feeling comfortable with all these things rather than previously they used to come to our casualty with a very severe asthmatic attack. So now we are getting, I think, less patients with all these newer medicines. Thank you, sir. So on behalf of our IMA Pune, sir, I will like to felicitate you. I request our president, Dr. B.S. Deshmukh.
मेरे यहाँ खुद ही वो technical glitches हो गए. मैं बारे बात करता हूँ.
Just a minute, Dr. Bhartwal, sir.
हाँ जी.
Yes, sir. We'll be felicitating you on behalf of IMA Pune. That's a nice. Piyush, can we see Dr. Bhartwal, please?
Yeah, madam. Yes, I can. Yeah, madam. Thank you, madam. This is a online.
Yes, sir. And this is our IMA Uparna.
Thank you, madam. Thank you so much for this honor. I'm grateful. Thank you so much.
For you.
And this is a diary. So we'll be giving this everything to you. Okay.
Thank you, madam. Thank you so much. Thank you. Grateful.
Mr. Nagendra?
Yeah, can I begin my introduction of Dr. Inge?
Yes.
Oh, okay. Can I just chip in interest of time, we'll skip the introduction or we'll keep it very, very short, and you can stop sharing the screen and I'll start sharing so that by the time you introduce me, I'll set up with the presentation.
Nagendra?
Yes, sir.
Yes.
Yes, sir. I will give you very short introduction. As already during this lecture, Dr. Bharatwal has introduced partially to Dr. Lakshmikant Yange. Dr. Yange, MD/DN Internal Medicine and DM Pulmonology Critical Care Medicine, sir, associated with Dinanath Mangeshkar College. Sir has a lot of publications and graduation as well as postgraduate from PGI Chandigarh. Sir, also associated with AIMS Delhi and the well-known personality across the India, Dr. Randeep Guleria, for quite long period of time. And sir has a lot of publications and more than 15 years, 17 years experience in the field of pulmonology as well as critical care medicine. So I don't want to take the much time as Dr. Yange has requested. So Dr. Over to you, Dr. Yange.
So can you stop sharing so that I can start sharing? Okay. Okay, thank you, IMA Pune, once again for giving me this opportunity. Thank you, Dr. Barthwal, for the kind words, and thank you, AstraZeneca team, for supporting this activity. As usual, I'll not take much of the time. I'll just go quickly to the points which we want to discuss as basics of asthma and management of asthma as per the latest guidelines has been covered by Dr. Barthwal nicely, and I hope that definitely will change the perspective asthma is looked upon. Moving further, I'll dwell upon few important points, and these are the points which I'm going to discuss. One is OCS use in asthma, efficacy of biologics in asthma, then available biologics for asthma in India, differences between IL-5 and IL-5 receptor therapy. In short, I'll be very brief about this. Safety points regarding the biologicals, because any new drug comes, we have to be very, very wary of the safety, especially the long-term safety. So we'll be looking at the long-term safety and long-term efficacy of the drugs. And I'll conclude with some take-home points for everybody. So just I'll start again at the same point where Dr. Barthwal started. This has been the work from Pune itself, Dr. Salvi. And I'll just focus on some important other top points which Dr. Barthwal has not focused upon. So the number of or the percentage of people who of severe asthma who are actually on the oral medications or the pills was whooping 86%. And of particular interest is the fact that the inhalers, the syrups, and nebulizers, or inhalers and nebulizers, even if you combine together, they were not even 50%. So these, mind you, these are the patients with severe asthma and not all asthma patients. So even if the less than 50% of our severe asthma patients get inhaled therapy, this is very, very shameful topic for us, I would say. And this is Indian data, not Western data. So we have to be very, very cautious or diligent about these things. Moving further, odds of
मेरा मैक के साथ मैंने सुबह देखा भी था, मैंने I actually shared the
yes,
link with the residents.
I think Dr. Barthwal, can you please mute, sir? Okay. So odds of moving on, what are the harms oral corticosteroids can actually cause? So these are the harms oral corticosteroids can cause. If you look at the odds ratio, almost all cardiovascular as well as metabolic, psychiatric, cataracts, and all these things are more than 1 to 2 is the odds ratio. However, most striking is for these two. One is the dyspeptic disorders, odds ratio of 4, and osteoporosis, odds ratio of 5 or more than 5. So these two important side effects we need to take into consideration whenever we are actually prescribing oral corticosteroids to patients for any indication, more so for asthma. And moving further, 93% of the patients with severe asthma have at least one OCS-related adverse effect documented. So another important fact I want to highlight is that this is the recent or latest guidelines, GINA guidelines, wherein we can look at step 1, step 2, step 3, step 4, and step 5 treatment. And if we really carefully look at the step 5 therapy, The preferred controller regimes recommended are add-on LAMA or refer to phenotypic assessment, anti-IgE, anti-Il5, IL5 receptor therapy, or anti-IL5, IL4 receptor therapy. Consider high-dose inhaled corticosteroids, formoterol. Surprisingly, the oral corticosteroids are missing from this regime in both preferred track as well as the alternative track. So we are using therapy which is not at all recommended as a first-line therapy by GINA guidelines. Why so much of discrepancy? It's something which we have to ponder upon. There are no oral corticosteroids in the treatment of asthma. So the important point here I would like to make is that whenever you are considering oral corticosteroids, long-term oral corticosteroids, I mean to say, short-term oral corticosteroids are okay. They are recommended for rapid symptom control in preferred as well as alternative track, but not long-term. So oral corticosteroid as a maintenance therapy for asthma is not first-line therapy. If at all we are considering this therapy, it is second-line therapy or not as per guideline therapy. And we'll have to consider that in some patients, but after exhausting all other options. That is the first important point I would like to drive home. Moving on, phenotyping asthma. So these are the largely groups which we can identify based on either sputum eosinophils or blood eosinophils and serum IgE levels. As the serum IgE is on higher side, they are more likely to be atopic asthma. High IgE with high eosinophils, it falls here. So atopic as well as eosinophilic. So all the three biological therapy which we are going to discuss will be helpful, useful in this particular group. In this particular group, only anti-IgE therapy will be useful. And in this particular group where the blood eosinophils are high, but serum IgE is less than 30. In this particular group, this is non-atopic eosinophilic group where only eosinophil targeted therapy will be useful. And this is the most difficult to treat group where neither eosinophils are raised, less than 300 eosinophils and less than 30 IgE. This is the group where small proportion will be benefited by eosinophil targeted therapy if their eosinophil count is more than 150. If eosinophil count is less than 150, none of these are going to be useful. The options left there are bronchial thermoplasty, macrolides, long-term macrolides, which is azithromycin, and weight loss, because this is the subgroup of patients who are more late onset obesity associated asthmatic. So controlling weight, reducing weight, making lifestyle changes, controlling gastroesophageal reflux disease, controlling infections, and using macrolides as an immunomodulatory therapy and not as an antimicrobial. The regime is different. If time permits, we can discuss that regime. And about bronchial thermoplasty, if time permits, we can discuss that also. So this is largely the second take-home message for most of us in this particular topic. So moving further, how can we take patients who are already on oral corticosteroids off? If they are on short-term oral corticosteroids, they can be taken off oral corticosteroids quickly. Rapid dose tapering or sudden withdrawal is feasible. But if the patient have been using these drugs for a very long period of time, abrupt withdrawal is likely to cause problems, adrenal insufficiency. So either we can go very slowly and taper and stop steroids, monitoring for signs of adrenal insufficiency. So moving further, there is important concept called low dose, medium dose, and high dose inhaled corticosteroids, and many times we get confused, especially when we are looking at the stepwise treatment of asthma. We need to be aware of these, and most of the times either we'll be using budesonide or fluticasone as a drugs, and the corresponding doses for low dose are 200 to 400, 400 to 800 medium dose, and 800 more than 800 is high dose. And similarly, for fluticasone furoid, even 100 microgram per day is low and intermediate medium dose, and more than 200 is high dose. And fluticasone propionate, the same dose is up to 250 is low dose, 250 to 500 is moderate dose or in medium dose, and more than 500 is high dose. So once these distinctions are made, we'll move on to the core area of interest, efficacy of available biologicals for the treatment of asthma. First is exacerbation reduction. Benralizumab, mepolizumab, and omalizumab have been studied for these indications. The doses studied are different. For benralizumab, the dose is constant throughout. For mepolizumab, doses are different for different trial, but available dose to us is 100 milligrams, so we don't have to get confused with different doses. Different doses have been found equally efficacious, starting from 775 to 750 milligram. So we'll stick to 100 milligram and we'll ignore the doses for the time being. For omalizumab, we have to calculate dose based on IgE level and weight of the patient. So that is why it is slightly difficult therapy to choose and utilize when we are dealing in clinical practice. If you look at the efficacy wise, to reduce the exacerbation rate, all three are largely effective to the tune of 50%. Exacerbations reduced by 51%, exacerbations reduced by 48%, exacerbations reduced by 48% for all the three drugs respectively at 48, 52 and 52 weeks. So largely they look almost similar if you look at them superficially. Efficacy of the drugs for oral decreasing the dose for taking them off oral corticosteroids, and the different set of trials have been conducted for these drugs again. We'll forget the doses again, as I have already said. So the median dose reduction with benralizumab was 75% as compared to 25% in placebo. And for mepolizumab, the dose reduction was 50% as compared to 0% in placebo. So such sort of trials are little difficult for me to digest, because even placebo, when enrolled in trial, gives rise to some effect, which is starkly lacking in this particular trial. So this trial I would take with little pinch of salt. Omalizumab, again, dose reduction was 43% at 12 weeks, at 12 months, and 50% reduction. 50% patients were free of oral corticosteroids. So there is difference. The 75% is amount of dose decreased. This is again the 50% amount of dose decrease, but this is about 50% of the patients are actually taken off steroids. So there is slight difference in the trial. So if you ask me which one is most effective, I would say omalizumab possibly is most effective because it is taking 50% of the patients off dose. But again, we'll compare that in subsequent trials. Just coming to the clinical utility, which drug to use, when to use, and how to use. So these are the three drugs. Omalizumab is the oldest one which is available from 2001 for various indications, so almost 22 years experience. It is indicated for moderate to severe persistent asthma uncontrolled by ICS in more than 12 years of age. Recently, it has been approved for more than 6 years of age also, but the approval for same is pending in India. Mepolizumab is again approved for more than 18 years of age. It has been approved for more than 12 years of age internationally. Indian approval for more than 12 years of age is pending. The dose is 100 micrograms, 100 milligrams subcutaneous weekly. And benralizumab is approved for more than 18 years of age. Internationally, it is approved for more than 12 years of age. And the approval for Indian patients is awaited. So the dosing is 2 to 4 weekly depending on the weight and IgE for omalizumab. For mepolizumab, it is 4 weekly standard dose, and for benralizumab, it is first 3 doses every 4 weeks, and then after that, it is every 8 weeks. All the 3 drugs are to be started and given indefinitely. There are some data wherein we can stop them after 1 year, 3 years, and see whether the response is maintained or not. And if there is no response, there is relapse or recurrence of the symptoms, we can restart. However, that is not very robust data. At present, indication is to just continue when started. Now, how do they help? So this slide will give us idea how individual agent works. Anti-IgE, it binds IgE. So many a times we tend to repeat IgE levels after we give omalizumab, which is actually a wrong practice, because the actual levels of IgE will be increased because it is just binding the IgE and it is not eliminating the IgE from the blood or the body. So the IgE is not a marker for response evaluation after we give omalizumab for any indication for that matter. And then what it happens, what it does is it actually blocks the further downstream mechanisms and prevents the IgE from having its effects. Moving on to the anti-Il5 therapy, mepolizumab actually binds to interleukin-5 molecule, and then it prevents its action from happening at the interleukin-5 receptor. Further, interleukin-5 receptor antagonist benralizumab actually binds to the receptors on the effector cells, and then it prevents the binding of interleukin-5. Not only it prevents the binding of interleukin-5, but also it induces the antibody-mediated cytotoxic destruction of the eosinophils. So it actually leads to near complete depletion of the eosinophils, and this is what we will get. The difference of different mechanism of action for mepolizumab, it binds to the interleukin-5 and it prevents its action on the interleukin-5 receptor, whereas the benralizumab binds to the interleukin-5 receptor directly, and then it activates the natural killer cells and it leads to antibody-dependent cytotoxicity related eosinophil apoptosis. So benralizumab acts faster and achieves near complete depletion of eosinophils. So these are the principal mechanistic differences of the different biologicals. So it affects eosinophils almost within 24 hours, and after 2 days you may get almost 0 eosinophils. And in airways, it leads to almost 96% depletion of eosinophils. That is regarding benralizumab. Now, just moving on to the review of the efficacy studies. I'll not take much of the time. We'll go little faster through these studies for the lack of time. Okay, so we are almost reaching the near end of session, so I'll skip this. We'll just focus on important points like cumulative efficacy and sustained efficacy of benralizumab over 1 year, 2 years, and 5 years. The efficacy goes on increasing 63% of the patients versus 74% of the patient versus 87% of the patients. So as the duration goes on increasing, the number of exacerbation goes on decreasing if the patient continues to take benralizumab. Overall efficacy is almost 93% reduction in exacerbations for the patients with benralizumab. Decreasing the dose of steroids, again, benralizumab also leads to almost 52% patients off steroids, and exacerbation-free patients at 6 months were almost 77% in the benralizumab trial. So efficacy of both the drugs for oral corticosteroids, sparing data, median reduction in dose 75% versus 50% that we have already reviewed, and whether the lung function improvement is sustained. For benralizumab, there is immediate improvement in lung function, starts within 4 weeks, peaks by almost 16 weeks, and it is sustained even at the end of 1 year and even at the end of 2 years in the extension study. So by end of 2 years also, the lung function is actually sustained. The same thing actually does not happen with mepolizumab. Lung function has actually improved initially, but by 48 weeks, it starts declining again. And in extension study, it actually goes less than the baseline level. So the sustained effect is seen in benralizumab. However, it is not seen in mepolizumab in long term. I'll skip this slide, and the efficacy of benralizumab in patients who have already received other biological agents. So the exacerbation rate pre-mepolizumab, end of mepolizumab, 24 weeks of benralizumab and 48 weeks of benralizumab, you can see there is significant difference. The exacerbations have come down annually from 4 to less than 2 in patients who still had 4 exacerbations on mepolizumab. So it is definitely effective in patients who have been previously exposed. Moving on to the oral corticosteroid dose and lung function. So almost everything tends to improve in patients who are switched from mepolizumab to benralizumab. Moving on to the safety. I'll not go into the details. Just rest assured that I have reviewed the numbers and the available biologicals are well tolerated and side effects are minuscule, largely to the tune of placebo. So how do we evaluate the patients with asthma for biological therapy? So we have to address these factors. Dr. Barthol has dwelled onto these topics, so I'll not go into details. Moving further, education is important. Optimize the treatment again. This comes again and again. Treat the comorbidities. All these are important points. Once we have identified the true difficult to treat asthma, we'll confirm the diagnosis, look for contributing factors, optimize treatment once again, review the response after 3 to 6 months. So the severe asthma and the consideration for biological therapy usually takes place beyond 3 to 6 months of careful follow-up by the patient. So I always say I will not consider biological therapy for anybody unless he has followed with me for at least 3 months to 6 months. No patient who comes to me will get consult for biologicals in the first or second month of therapy. Once we have assessed the true refractoriness despite optimization, we'll phenotype the patient. Though the phenotyping can be done at the initial diagnosis, but the true role of phenotyping comes here. And once the phenotyping is done, then we'll come down to the therapy. So these are the responses, different risks as plotted against the eosinophil level. I'll not go into the details. Just rest assured that higher the eosinophils, higher the symptom burden, higher the chances of exacerbations. Are there any clinical pointers where we can think that asthma is eosinophils? Eosinophilic elevated blood levels definitely is a marker. Responsiveness to the oral corticosteroids is one marker. Frequent severe exacerbations, late onset disease, association with chronic rhinosinusitis or nasal polyposis, and low FEV1 despite bronchodilator therapy. These are the pointers wherein we can think that asthma is likely to be severe and eosinophilic. How do we measure the eosinophils? Sputum versus peripheral blood. Peripheral blood is most the convenient one. So I'll skip that. And this is once again, the phenotyping slide with drugs which are useful for specific phenotypes. We can discuss that if time permits. To summarize, scope of biological therapy for asthma is expanding. 3 biologicals are available in India at present. Omalizumab and mepolizumab available. Are approved for more than 6 years of age internationally. In India, they are approved for more than 12 years, and Benrali is approved for more than 18 years in India. Globally, it is approved for use in more than 12 years of age. Head-to-head comparisons are not available for any of these biologicals. Benralizumab appears latest addition and appears to be effective in those who have failed other 2 biological agents. Benralizumab is one with the minimum number of doses and convenient dosing regime available at present. I thank you once again for giving me this opportunity, and I hope that this helps our patients in clinical practice. With this, I hand over to the organizers for further.
Yes, thank you, Dr. Yenge, sir. It was a very nice discussion on this, and I think we have attended one more lecture of yours on this biologics. So really, it is a very effective drug, and hope the people who are suffering, they get cured. So with this, I request our president, Dr. B.L. Deshmukh, to felicitate you.
Oh, thank you. Thank you, sir. Thank you. Thank you.
And
yes, sir. Thank you. Thank you. I'll collect some time.
Yes, sir.
Okay,
Yes, sir.
okay, definitely.
And this is a New Year diary, sir. Just from 1st April.
Yes, ma'am. Thank you. Thank you.
Thank you. Thank you. We'll be meeting, sir, on 3rd
Yes,
April.
ma'am.
Yes. Thank you. Thank you. Mr. Nagendra?
Yes, ma'am.
Sir, alet ka? Dr. Sunil Sati, sir?
Yes, ma'am. Yeah, here onwards, ma'am, the respiratory and immunology, the symposium is over, and here onwards, I think cardiovascular renal metabolic symposium will start.
Yes, yes, yes.
So over to you, Nimesh.
Okay.
So, sir, we have Dr. Sunil, sir. Sunil, sir, please over to you, sir.
Yeah, okay.
Thanks.
Thank you. Welcome, everybody, for this cardio-renal symposium. We have 4 eminent speakers today. All of them very well known to all of us, and extremely brilliant cardiologist, nephrologist, and endocrinologist with us. We'll start with Dr. Ajit Bhagwat from Aurangabad, a very close friend, and Dr. Ajit Bhagwat is a famous international cardiologist from Aurangabad, but more important, he's one of the best academicians I have ever seen. There is rarely a national conference where he is not invited. So he will be talking on integrated heart failure treatment approach and the role of Dapa. Over to you, Dr. Ajit Bhagwat.
Thank you, Dr. Sate, for a very kind introduction. I hope you can hear my voice.
Yes.
Okay. Now I'll share the screen. Can you see the screen?
Yes, sir, you can start. Yes. Yes, sir.
Okay, so good evening, everybody. So at the outset, I would like to thank the organizers, the IMA Pune, for asking me to interact with all of you in this August meeting. Today, I will be talking about Dapagliflozin in treatment of heart failure. Now, I understand that most of the physicians in the audience are either physicians or general practitioners. So I think it is important for everybody to get introduced to this topic, because this is something which is which has probably revolutionized the treatment of heart failure, particularly heart failure with reduced ejection fraction. So if you really look at the heart failure with reduced ejection fraction, the current treatment modalities that we have are either ACE inhibitor or ARBs, and guideline directed medical therapy with beta blockers and diuretics as needed. Now, apart from RAS inhibition and beta blockers, what else do you use and how do you use it? Now, when patient is symptomatic and his creatinine and potassium is all right, aldosterone antagonists are one of the most important group of drugs which are used in these patients. This could be spironolactone or more specific antagonists like eplerenone. If patient is already on ACE inhibitors or ARBs and there is no contraindication, you can switch to sacubitril valsartan, which is also called as ARNI. Now, this is not for us in United States. When you have African American individuals, isosorbide with hydralazine combination is one of the important combinations which is used. And then ICD, cardiac resynchronization therapy, and to reduce heart rate, ivabradine is also used. The most important drug which has been added to armamentarium is a group of drugs called Hgl2 inhibitors. Now, these are basically anti-diabetic drugs, and let's see what's their impact on treatment of heart failure and how to use them. Now, if you really look at the effect of these drugs in mortality in heart failure or reduction in risk of hospitalization and mortality, you can see that once beta blockers are added to ACE inhibitors or ARBs, the benefit goes from 17% to 43%. Now, when you when you use a combination of these two, actually this is only with beta blockers. If you use a combination, the benefit is incremental, and it from 43% it goes to 53%. Now, if you add a mineralocorticoid inhibitor to this, the benefit further increases to 56%. And when you combine ARNI, beta blocker, and mineralocorticoid inhibitors, there is sacubitril valsartan plus a beta blocker and a mineralocorticoid inhibitor, the benefit is quite whopping. The risk reduction is by 63%. So, what next? Now, the group of drugs which we're going to talk about are Hgl2 inhibitors in heart failure. And the entire evidence of use of Hgl2 inhibitors in heart failure, it started coming from this seminal trial, which was EMPIRIC outcome trial. In this trial, they took about 11,000 patients were screened who had diabetes with no or stable, patients with diabetes and established cardiovascular disease. Very important to remember. Diabetes with established coronary artery disease with no or stable anti-diabetic treatment. So they were diabetics, but some of them were on no treatment, some of them were on stable anti-diabetic treatment for 12 weeks. And these patients were randomized to empagliflozin, placebo, and empagliflozin was used in 2 doses, 10 milligrams and 25 milligrams. Now here, this drug empagliflozin, this is an Hgl2 inhibitors, was used as an anti-diabetic drug. And patients were followed for about 3.1 years. All these patients were diabetics, and this drug was used as an anti-diabetic drug. And what did they see? They saw a very, very remarkable set of findings. One, the fatal MI and stroke was significantly reduced. Individually, death from any cause or cardiovascular death was significantly reduced, or hospitalization for heart failure was also significantly reduced. So the combined endpoint as well as individual endpoints were very, very significantly reduced in this clinical trial. So this was very important to remember. Now here you can see that the curves start separating very early. As soon as you start the patient on drug, the curve starts separating and you see reduction in incidence of rehospitalization in these patients. See, the problem with heart failure patients are twofold. One is quality of life, and second is the length of life, the quantity of life. Now, as far as quality of life is concerned, recurrent hospitalizations is one of the most important negative factors. Patients are symptomatic, so that affects their quality. But recurrent hospitalization is also one of the most important things which affect the quality of life. And here you can see that that effect is very positively seen very early after starting these drugs. Now, in this trial also, there were 10% patients who had heart failure. However, this is likely to be an underestimation because echo and biomarker information was not available in this trial. So this trial was basically done on diabetic patients who had established coronary artery disease or cardiovascular disease. Only 10% had documented heart failure. Now, this next study which came was canagliflozin. This was another Hgl2 inhibitor which was used in cardiovascular and to study cardiovascular renal events in patients with diabetes. And again, a large number of patients was studied, and Cana was studied in 100 as well as 300 and compared with placebo. Now, in the previous trial which we showed on empagliflozin, I forgot to mention that the benefit was seen in both the doses, 10 milligrams as well as 25 milligrams, and both these effects seen with both doses was similar. So there was nothing to choose between the 2 doses. Now, what did they see with Cana? Now, important point which I want to make from this slide is canagliflozin was better than placebo as far as all endpoints were concerned. And as I told you, the primary endpoints were cardiovascular related death, non-fatal stroke, and non-fatal MI. Now you can see that canagliflozin was better in terms of every endpoint. And the interesting thing was, you can see here, hospitalization for heart failure and death from cardiovascular causes or hospitalization. So combined endpoint as well as individual endpoint, there was significant benefit of the drug. Now, when this was also seen in non-fatal myocardial infarctions. So, but you can see that the benefit as far as hospitalization for heart failure was concerned, it was, these 2 points were, this particular point, hospitalization for heart failure is much to the left of this particular point, which is seen in non-fatal MI. So what does it tell you? It tells you that the risk reduction for heart failure was double that of non-fatal MI, indicating that the heart failure benefit was independent of myocardial infarction. I hope you got this point. The reduction in myocardial infarction was far less than the benefit which was seen for hospitalization for heart failure. So this is important to remember. Now we'll come to the important trial of today's talk, and that is dapagliflozin in patients with heart failure. Now, with the 2 studies which I showed just now, just before this, people started wondering that this particular drug seems to have tremendous benefits, particularly in diabetic patients, as far as their cardiovascular endpoints are concerned. Now, one of the endpoints which was also found to be affected positively was hospitalization for heart failure and development of new heart failure. So people started wondering, and they started thinking that maybe this drug is beneficial for patients who already have heart failure. So this particular study was done in patients who already had established congestive cardiac failure, while the previous studies were done on patients who had established cardiovascular disease like coronary artery disease or blockages in the coronary. Heart failure was not the only cardiovascular abnormality. Actually, in fact, heart failure was seen in only 10% of those patients. But here, 100% of the patients were of heart failure. And in this trial, around 4,744 patients were randomized. They belong to class 2, 3, and 4 heart failure with EF of 40% or less. And they were randomized either to Dapa of 10 versus placebo, in addition to the standard guideline-directed medical therapy. And the primary outcome was a composite of worsening heart failure, that is hospitalization or an urgent visit resulting in intravenous therapy for heart failure, or cardiovascular death. All comers with heart failures were taken regardless of presence of diabetes. So these were not only diabetic patients. This is important to remember. These were all comers, diabetics as well as non-diabetics. And what did they see? They saw, this was actually the demographics of the patient. These are not the results. And you can see that most of the patients belong to class 2, about 30% to class 3, and very few belong to class 4. Mean ejection fraction was about 31%. NT-proBNP was elevated in all of them, close to 1400. Ischemic cardiomyopathy was seen in 55 and 57 in 2 groups, and rest of the patients had idiopathic dilated cardiomyopathy. The mean eGFR was 66. So, mild renal insufficiency patients were included. Now, diabetics patients were about 40-45%. So less than 50% were diabetics. So it is important to remember that most of these patients in this clinical trial were non-diabetic heart failure patients. And you have used a drug which is an anti-diabetic drug. So you must remember this. Now, what about the baseline background therapy? Now, 94% patients were on some RAS inhibition. It may be ACE inhibitor, ARB, or ARNI. But only 11% were on ARNI. So 90% were, rest of them were either ACE inhibitor or ARB. 96% were on beta blockers. This is very heartening to see that now people all over the world, are using heart failure beta blockers in almost all patients with heart failure. And this has been a recent finding, because if you see any old trial of heart failure, beta blockers were used in 50%, hardly 50% or 60% patients. MRA was used in 71% of the patients in both groups. This is mineralocorticoid receptor inhibitors. ICD was in 26% and CRT was about 8%. And these are the results. As far as primary outcome was concerned, cardiovascular death, hospitalization, urgent heart failure visit was reduced substantially, very significantly, with a p-value of very low p-value. And here you can see that the risk reduction was about 26%, and the number needed to treat was 21 patients for 3 years. So that's not very high. If you treat 21 patients, you will save at least one endpoint, either death, hospitalization, or urgent heart failure visit. All-cause death was also reduced. So that's very heartening to see. And this is this is when you split all the endpoints individual, and every individual endpoint was reduced by Dapagliflozin. Now, what about the side effects? Everybody worries about the side effects. This is an anti-diabetic drug. It produces glycosuria, so patients may get volume depleted. They may develop hypoglycemia, ketoacidosis, glycemic ketoacidosis. So these were all the worries, and you can very well see here that very interestingly, in fact, most of the side effects, almost all side effects, there is hardly any difference in the side effects. And in fact, some of the side effects were more commonly seen in placebo group. Now, for example, major hypoglycemia was seen in equally in two groups, 0.2%. Volume depletion, there is no difference. Renal adverse events, in fact, it was more commonly seen in placebo as compared to the drug group. There was some worry about amputations and fractures, but there was no difference. So this gives you a lot of security in terms of your ability to use these drugs in heart failure without worrying much about significant side effects. And what about worsening renal function? I already talked to you that number of patients who had significant renal dysfunction, 1.2% in Dapa group and 1.6% in placebo group. So more common in placebo than Dapa. Now, what about diabetics and non-diabetics? Now, this is a very important slide. If you see patients with diabetes and patients without diabetes, in fact, the benefit was more in patients. It was significant in both, very significant in both. But comparatively, it was more beneficial in patients who did not have diabetes. So I have, personally, I have come to a conclusion that these Hgl2 inhibitors are just basically they're cardiovascular drugs, and they just happen to be anti-diabetic. They're not primarily anti-diabetic drugs. It just happened that we came to know about their anti-diabetic effects first. But now we're realizing that they're basically a very, very robust cardiovascular drugs, which also happen to be anti-diabetic drugs, and they benefit patients who do not have diabetes without causing symptoms of other oral hypoglycemic drugs like hypoglycemia. So this is very important to remember. How does it compare with the effect of ARNI? If you really look at the hazard ratios of compare with Dapa and Paradigm trial, the benefit or the hazard ratios were reduced. The risk reduction was slightly better in patients who received Hgl2 inhibitor. Now, what about effects of these drugs when they are used in patients who are already on ARNI? Now, I've already told you that about 10% of the patients, 11% of the patients in this trial were already on ARNI. So it's a small number, but they took those 11% and compared their effect of Dapa in these patients. You can see that the effect was seen in patients who were on ARNI as well as those who were not on ARNI. So it doesn't matter. Sometimes it's very difficult to start the patient on ARNI. We have seen this in our clinical practice so often that sometimes patients have problem with blood pressure. His blood pressure is close to 85, 90, and you're worried about starting ARNI on him because of a fear of hypotension. His potassium is close to 5. So these are the patients where you can easily start these patients on Dapagliflozin. It is very easy, just one tablet a day. You don't have to titrate, and it doesn't affect blood pressure much. It doesn't affect potassium much. So you can see in this slide that patients with ARNI or patients without ARNI, it doesn't matter. And these are different individual endpoints are split in these 4 groups. The combined endpoint, cardiovascular death, heart failure, urgent visits, and all-cause death. In every endpoint is concerned. Patients benefit was seen in patients who were on ARNI as well as who were not on ARNI. So this slide we have already seen. So this is again a slide which is showing the benefit in terms of renal failure. You can see that there is one need not worry about renal failure in these patients. The only thing is, one should not take patients whose eGFR is less than 60. So what are the strengths of this trial? The benefit of this agent Dapa was seen in addition to the background therapy. This was seen, the benefit was similar in diabetics as well as non-diabetics. And the magnitude of benefit was similar to and reminiscent of ARNI in paradigm heart failure. So the magnitude of benefit is also very, very robust.
Excuse me, sir, you have got 5 more minutes, sir.
Yeah, I will be finishing before that.
Okay, sir. Thank you.
What are the limitations? 99% of the patients, where they belong to NYHA class 2 or 3, Background therapy with ARNI was seen in only 10%. So, we may need a bigger trial where, more than 60-70% patients on an ARNI, and then you can see what is its additional incremental benefit in these patients. And doses of drugs in background therapy are not reported. So what doses of ARNI were given, what doses of MRA was given, that was not reported. This is very, the important thing is it's very important to put the patients of heart failure on fabulous 4. What are those fabulous 4? Beta blockers, RAS inhibitors, MRAs, and Hgl2 inhibitors. Now, the easiest drug to start and to titrate is Hgl2 inhibitor, because you don't get potassium problems, you don't get hypoglycemia, you don't get hypotension, and you don't have to titrate the dose. It's just one dose and that's it. So that's very important to remember. So I'm not going to talk much about the mechanism of action of Hgl2 inhibitors, but just one important thing to remember: it's a class effect. It is independent of glycosuric effect. So very significant effect was seen in presence of only modest reduction in A1C. So even if the A1C reduces very modestly, the cardiovascular benefit is very, very robust. And the equivalent effect was seen across the groups with different degree of CKD. So you don't really need a particular level of renal function to see the benefit. So it has been already approved by our government for use in heart failure. So in conclusion, Dapagliflozin is safe and effective in treatment of heart failure with reduced ejection fraction. Its effect on morbidity and mortality is over and above the current drugs which are used in heart failure, and it has the same effect in diabetic and non-diabetic patients. So thank you very much for your hearing.
Thank you, Doctor. Thank you, Ajit, for an excellent talk as usual. Just quickly, 1 or 2 questions I'm going to ask you. See, do you think today, with so much data, a general practitioner, family physician, suppose they have so many patients in their OPDs who have LV dysfunction and diabetes. So can this be drugs started at their level, number 1, straight away? And what would you advise them regarding, what should you tell the patients? Today, what I think is, whether I'm a cardiologist, physician, or a general practitioner, I think family physician, we should be able to start Dapa easily. So what is your take on that? And what would you advise them? When should you look at serum creatinine, serum potassium, if you start Hgl2 inhibitors?
Yeah, these are all very important questions, but they're beyond the scope of the time. So I will answer it now. I think this drug is the least complicated drug in terms of use in treatment of heart failure, as I mentioned earlier. Now, the thing is, when you use any of these drugs in heart failure, first of all, I think is you should be used to treating patients of heart failure. That is very important. Just you see on a note that patient has heart failure, it's not appropriate to just start the patient on heart failure drug. You should be used to evaluate the patient for heart failure, clinical evaluation, and then start the patient in a stepwise fashion. Suppose patient is volume overloaded. Now, this is not the point where you are going to start these drugs. So make sure that you give the patient diuretics first, make them euvolemic, and then use either ARNI or Dapa or beta blockers in these patients. So there is some art and science in terms, when you use these drugs in heart failure. So my advice would be, rather than just one day starting these drugs on all patients with heart failure, you may talk to some people or see how these drugs are being used by people who are used to use it. Many cardiologists use it, and then slowly get confidence in terms of using these drugs and then start using it. It's not difficult to use at all, but at the same time, sometimes you can create problems if you use these patients in volume overloaded patients. You don't want to do that. With this drug, you won't produce much problem, but with beta blockers or other drugs, there could be serious problems. So that is what I would like to say. And then about the laboratory study, these patients are very, very fragile patients. Heart failure patients, sometimes you see the patient in the morning, and patient is absolutely stable. You give him a lot of encouragement, and in a couple of days, he's 2-3 days, he's back to the hospital in a volume overloaded state, or you hear that he's dead because of VT, VF, or sudden death. So these are fragile patients, and you need to be very careful about these patients, and you have to monitor their volume status every time. Urea creatinine, at least initially when you are adjusting the dose, and serum potassium, most important thing, because sometimes the patient looks good, everything is fine, and the potassium is climbing, which you don't realize, and patient has sudden death because of this. So there are a number of things which we can discuss, but this was in short that I would like to say.
I think, thank you. This is just the message is that these are drugs which are now mandatory for heart failure patients. But yes, there's a caution. So you must know about these drugs, when to use, when not to use. And that is the message. So very important drugs to be used, but be careful, be cautious, and use it appropriately in patients with heart failure. Thank you, Dr. Bhagwat. Now we'll move on to the next talk.
I'll
Yes, any
Sir, felicitation from IMA Pune, Dr. Bhagwat, sir.
This is bouquet for you.
And we'll
Thank you.
be sending you.
It was an honor and a privilege to be here today. Thank you very much.
And this is a IMA diary also. So we'll be sending you. Okay, sir. Thank you. Thank you.
I will pick it
Thank
up.
you, Dr. Bhagwat. We will move on to the next talk. We have Dr. Ambike. Most of you know him. He's an excellent nephrologist, and today he's going to talk on basically CKD patients and Dapa. Is there something different or a new hope with this drug for CKD patients? Dr. Ambike, please.
Good evening, everybody. It's my great pleasure, and I thank IMA and the organizers AstraZeneca for having given me this opportunity to share my views on, I wouldn't say a new drug, which we've been using almost for the last 2 years now. As far as CKD and progression of kidney disease is concerned, there was not much that was happening for a very long time after the advent of ACE inhibitors and ARBs. Nothing was coming forward which could actually retard the progression of CKD, which is our primary concern as far as treating nephrologists are concerned. If you can prevent someone from worsening his kidney function, going on to a stage of requiring dialysis, you have achieved quite a bit. So after a long time, as I said, we have certain drugs as a group, and Dapagliflozin as a molecule, which is useful in preventing the further progression of CKD, especially in type 2 diabetics and also in non-diabetic kidney disease patients.
Sir, sir, we are not able to see the screen.
I have started sharing my screen. Is it not visible? Hello?
No, it's not visible.
It's not visible, sir.
1 second now.
Yes.
Am I audible?
Yes, sir. You
Yes,
are
sir.
audible?
So you can just click on this green button, share screen.
तुम्ही ज्या व्यक्तीला कॉल करत आहात ती ह्या वेळेस उत्तर देत नाही. कृपया थोड्या वेळाने प्रयत्न करा. The person you are calling is not answering. Please try later. आप जिस व्यक्ति को कॉल कर रहे हैं वह उत्तर नहीं दे रहा है. कृपया कुछ समय पश्चात प्रयास करें. आप ज्या नंबरवर कॉल करीत आहात.
Yes, sir.
Dr. Ambike, are you still there?
Yeah, I'm there. I'm just
Okay.
trying to figure out why my screen is not getting shared. On my laptop, I'm able to see the screen. Give me a second. I'm just trying.
Piyush, can you help, sir? Piyush?
Is it come now? Hello. I'm
Yes,
seeing a
yes,
logo
yes,
saying
yes.
that you are screen
Uh,
sharing.
Yes,
Yes, sir.
now we can see.
Yeah.
तर फुल स्क्रीन करा ना.
हो 1 second. हा तेच करतोय. Yeah, is it okay now? Hello.
Yes, sir.
Yes, yes, we are okay.
Yeah, sorry for the this thing, technical failure. As I was saying, for a very long time there was nothing happening as far as progression of kidney disease and retarding the progression was concerned. Initially there was a lot of enthusiasm when the ACE inhibitors and ARBs and the different trials that proved them beyond doubt to retard the progression by their antiproteinuric effects, especially in diabetic kidney disease. But for a very long time, we didn't have much to offer to our patients as far as retarding their progression was concerned. So after a long time, we've had this group of drugs, the Hgl2 receptor inhibitors as a group, and Dapagliflozin, with which it has been tried in non-diabetic kidney disease also, wherein we can offer something to our patients to prevent the progression of kidney disease. Now, most of our patients, fortunately or unfortunately, do not have a lot of symptoms till they progress to a stage where the kidney failure is quite severe and they manifest their uremia at a very late stage. So by various studies, almost about 60% of our patients with CKD will not be diagnosed or will go undiagnosed unless you do specific tests and you are watchful to do their creatinine levels, to calculate their eGFR, and to see what their albumin creatinine ratio or their protein excretion is. In one study, the Cure CKD registry, as I said, almost about 60% of the patients went undiagnosed. Also, CKD awareness amongst these patients, for some reason, they do not like, or it is still probably taken as a taboo, saying that kidney failure means the life expectancy is limited. There's not much to look forward to. And most of our patients are either unaware or probably are in a denial mode as far as their diagnosis of CKD is concerned. Now, the burden of non-atherosclerotic non-atherosclerotic cardiovascular disease, including heart failure, it predominates as the CKD progresses. So as one goes down the line, meaning as one progresses from CKD stage 2, 3 to CKD 5, these heart failure, left ventricular hypertrophy, arrhythmias, arterial calcification, all these risks, apart from the coronary artery diseases, also increases. And as all of us know, CKD by itself, because of it being a pro-inflammatory state, is an independent risk factor apart from the standard risk factors which the cardiologists particularly go into and look forward to, like hypertension, diabetes, hypercholesterolemia, smoking. So we should look at CKD as an independent risk factor for progression of not by itself the CKD, but also for progression of non-atherosclerotic and atherosclerotic coronary artery disease. Now, what do we look at, or how do we diagnose CKD? All of us are aware that serum creatinine by and large is the most commonly commonly looked into investigation for diagnosing of CKD. But we all know that serum creatinine measurements have their own limitations, and eGFR is the one which we should be looking at, which should tell us, or which tells us about the diagnosis of kidney disease. Here again, apart from meaning quite a few people would be monitoring the creatinine, but urinary albumin creatinine ratio, which is an earlier marker, which I would say is the first marker, or which is the first abnormality as far as the biochemistry is concerned, which begins with the damage to the kidney disease, that is very often underestimated or not tested at all. So almost about 80% of patients did not have a single urinary albumin creatinine ratio tested over 3 years of follow-up in the US healthcare organizations. Similarly, although about 94% of patients were tested for EGFR, only about 56% were tested for albumin creatinine ratio or protein excretion in the urine. And as all of us are aware, urine albumin creatinine ratio or urine proteinuria is an independent marker for worsening of coronary artery disease and worsening of CKD. Now, as I said, how do we measure? There are two things about diagnosing CKD. One is the actual kidney function. And apart from the kidney function, someone's kidney function may be normal. Someone may be having a GFR which is close to about 90, which we take as normal, 90 ml per minute per 1.73 meter square area. But he would be having some other markers which also need to be looked into, like, as I said, urinary albumin excretion rate or urinary albumin creatinine ratio. So these two things should be taken into account or should be considered when someone is assessing the kidney function and the damage. As I said, serum creatinine is by and large the most commonly investigated laboratory investigation done. Addition of cystatin C may add to the increased accuracy of diagnosing CKD. Apart from the function, we have other parameters, other kidney function, just not the excretory function. So urinary albumin excretion rate of more than 30 milligram per 24 hours, or an albumin creatinine ratio of 30 or more than 30 per milligram per gram of proteins. Now, the microscopic examination is also important. That tells us how badly damaged the glomeruli are. So urinary sediment, presence of RBCs, presence of CARs, presence of pus cells, again indicates a kidney damage. Electrolyte abnormalities in the form of hypokalemia, hyperkalemia, due to different distal and proximal tubular disorders. Now, if there are some abnormalities on histopathology, if someone undergoes a biopsy for some reason, say he has a nephrotic range proteinuria, or if he has some abnormality or worsening of kidney function of undiagnosed etiology, then we do a kidney biopsy, which again tells us about the kidney damage. Then a lot of imaging, with the imaging modalities getting better by the day, ultrasound becomes one of the primary investigations that we do to assess the kidney damage. And if there is a history of kidney transplant in the past, that by itself indicates that that patient has had a kidney disease or a kidney damage in the past. And most of our patients, even with a normal creatinine post-transplant, would have a CKD stage 3. Now, when do we intervene or when do we intervene or take measures to prevent the progression of CKD? The earlier the intervention, the better is the long-term outcome. So when someone is diagnosed early, intervention as early as a GFR of say more than 70, 75 would definitely prevent the worsening of kidney function, as is shown by this graph. We have the black solid line, which shows in a patient, someone who is either not diagnosed or has not been following up or has not been subjected to any intervention. He would probably land up with end-stage renal disease in about 7 years after the initial diagnosis of CKD. As against that, if there is a late intervention, meaning the patient has been diagnosed and for a very long time, for almost about 4 years, as per the graph, he has not been followed up regularly or he has not been subjected to any intervention to prevent the progression, he would take about 9 years, as against someone who from the beginning is under proper surveillance, under proper intervention, considering the progression of kidney disease, he would take say around 11 years for him to reach end-stage renal disease. These are the two trials wherein the Hgl2 inhibitors were tried. Now let us go to the topic of today's discussion, the Dapa Ckd trial. Now, this was, as I think it must have been discussed earlier, there was a robust more than 4,000 patients who were included in this trial. It was a mixed cohort of diabetic as well as non-diabetic patients. This was the first trial wherein the non-diabetic patients were included. The inclusion criteria, as every one of us know, was patients with more than 18 years of age. It was a broad eGFR, meaning right from stage 4 up to class 1, stage 1 CKD, meaning GFR of as low as 25 ml per minute per meter, 1.73 meters square, to CKD stage 1, that is 75 ml. Then again, the proteinuria also, there was a broad range of people who were included, patients who were included, as low as microalbuminuria, that is between 30 to 300, to gross or overt proteinuria or nephrotic range proteinuria that we always say. And all of these patients, mind you, were on primary preventive measures, which were standard of care. Like these patients were on stable doses of ACE inhibitors or ARBs for more than 4 weeks, unless of course these two drugs were contraindicated for various reasons that they are contraindicated. Now, as I said, more than 4,000, that is 4,300 patients were randomized and divided into two groups, the arm group and the placebo group. The primary endpoint was a composite of sustained increase in the GFR, drop in GFR by more than 50%, or reaching end-stage kidney disease or cardiovascular or renal death. So patients, this was the primary endpoint. And what was the outcome? Almost about 40% reduction was found in increase in decline in the GFR by more than 50%. All-cause mortality, that was another primary endpoint. There was a reduction of about 31% reduction in all-cause mortality. 44% reduction in composite outcomes of decline in GFR by more than 50% or end-stage kidney disease or renal death. And it also was helpful in cardiovascular deaths or heart failure, a relative rate reduction of around 22%. The safety, Dapagliflozin was a safe drug with not much of adverse side effects. The trial was stopped early because of an overwhelming benefit against the placebo group. Dapagliflozin was also found to reduce new onset type 2 diabetics in patients who were non-diabetic to begin with in a CKD population. So at the end of almost about 32 months, there was about 20% reduction in people or new onset diabetes on Dapagliflozin. Now, going through all these trials and these findings, what do we conclude? The Dapagliflozin addresses the cardiorenal burden across the spectrum of all patients. So heart failure and renal complications are frequent, early, and under-recognized in patients with type 2 diabetes and have a high morbidity and mortality. It reduces the cardiorenal burden beyond the glycemic control across the spectrum of all diseases or all stages of CKD, right from stage 1 to stage 4, I would say, to a GFR of about 25. The DECLARE trial, there was a 17% reduction in cardiovascular death or heart failure. There was 27% reduction in heart failure and about 47% reduction in eGFR decline or patient reaching end-stage kidney disease. The Dapa HF trial, there was a 26% reduction in cardiovascular deaths, consistent benefit in primary endpoints in patients with or without type 2 diabetes, regardless of the use of background GLT in patients with type 2 diabetes. Now, what does the ERA EDTA consensus statement suggest? We can divide the patients into two groups. In patients in whom the HbA1c goal is not achieved, meaning patients with type 2 diabetics, CKD, and who do not have an HbA1c goal, or who have a HbA1c of more than 7. So patients with type 2 diabetics, this is the ERA, meaning European Renal Association and European Dialysis Transplant Association recommendations. Patients with type 2 diabetes and CKD not at a target HbA1c of less than 7, they are either on recommended doses of metformin, or metformin is not tolerated or contraindicated. Then SGLT2 inhibitors with evidence of cardio and nephroprotection should be started. If HbA1c is still not achieved, then or if SGLT2 inhibitors is not tolerated or is contraindicated, GLP-1, that is glucagon polypeptide antagonist, one receptor agonist with evidence of cardio and nephroprotection should be added. Then if the sugars are still not controlled, another anti-diabetic agent either from DPP-4 inhibitors, thiazolidine group, or sulfonylureas or basal insulin is recommended according to the current recommendations. As against that, if the patient has a stable or has an HbA1c goal which is less than 7, or meaning he has a fairly good control, if he is not on SGLT2 inhibitor, switching over to a SGLT2 inhibitor is recommended. If HbA1c is not at goal or SGLT2 inhibitor is contraindicated, then as I said, GLP-1 receptor agonist is added. We reassess the HbA1c in 3 months and adjust accordingly. Most patients with type 2 diabetes, CKD, and eGFR of more than 30 ml per minute per 1.73 meter square benefit from SGLT2 inhibitor treatment regardless of CKD stage level or their level of hyperglycemia. So as everyone knows, the initial line of treatment is lifestyle measures, correction, physical activity, nutrition, weight loss. First line therapy when the GFR is more than 30 ml per minute per 1.73 meter square. If the eGFR is less than 45, metformin at a reduced dose is recommended. We normally reduce the dose to half what the dose initially was. If the patient is on dialysis, or if the GFR is less than 30, meaning stage 4 and stage 5 CKD, then metformin should be discontinued for the risk of developing lactic acidosis or metabolic acidosis, which these patients can have. SGLT2 inhibitors, if the GFR is less than 30, then there is no need to stop SGLT2 inhibitors. Up to about 25 mL GFR, all of us are using or we are continuing if the patients have been on Hgl2 inhibitors. Then the second drug is the GLP-1 receptor antibodies. After that, if the sugars are not controlled, then the other drugs which all of us use like DPP-4 inhibitors, insulin, sulfonylureas are recommended. Now, the 2021 KDIGO guidelines, early identification and intervention algorithm to screen, risk stratify and treat CKD. So conditions which increase the CKD risk, all of us know, are hypertension, diabetes, cardiovascular disease, hospitalization, family history of kidney disease, obesity. So these are the risk factors for CKD. Now, when any of these risk factors are present, then we normally screen for presence of an already undiagnosed chronic kidney disease. We do a urine albumin creatinine ratio, and we do that is to assess any early kidney damage if there is no overt proteinuria. Of course, if the proteinuria on a dipstick is more than 1+ or 2+, albumin creatinine ratio will not be much of a significance, in which case we do a protein creatinine ratio or we do a 24-hour urinary protein excretion. Then we do the kidney function test by getting a serum creatinine and an eGFR estimated, and or if the facilities are available and if routinely labs are doing cystatin C, that adds to the accuracy of diagnosing the stage of CKD. If any of these following things are present for more than 3 months, that is, if the GFR is less than 60 mL per minute, or if the albumin creatinine ratio is more than 30 milligram per gram, or there are markers which we just discussed of kidney disease, then a diagnosis of CKD is made and the patient is subjected or advised to come for periodic repeat evaluations. Now then we classify or we risk the CKD stage. So identify and treat specific causes of CKD. So if there is a diabetic nephropathy, which is the commonest cause, diabetic and hypertension together would probably account for about 60% of our patients with CKD. So we try and control their hypertension, control their diabetes, put them on a diet which would probably prevent their further worsening. Then we stage them according to stage 1 to stage 5, depending upon what their eGFR is, and assess all other causes or preventable causes of CKD. Now, for going further, if the patient has a eGFR...
Sir, you have 5 minutes more.
Sorry?
You have 5 minutes more, sir.
Yeah, madam, I'll be just concluding.
Okay.
Then any nephrotoxic drugs should be avoided to prevent the further damage of kidney disease. When the GFR drops to less than 60 mL, or when the patient starts going into stage 3, the drugs which are renally excreted should be given in a lower dose to prevent their toxicity. We should avoid dual ACE inhibitors and ARBs, especially so to prevent the hyperkalemia that can happen because of the worsening kidney functions. Whenever there is a need to use contrast, say either a coronary angio or a CT with contrast, we need to take due precautions to prevent their contrast-induced nephropathy. When the GFR is in stage 3A, that is between 65 to 60, NSAIDs should be avoided. Again, for a stage 3B, similarly, we should avoid NSAIDs. Metformin at a dose of 50%, as I said, can be used till a GFR is about 30 with close monitoring. When the GFR drops to less than 30, when the patient is TKD stage 4 or 5, totally avoid NSAIDs, bisphosphonates, metformin. PICC lines should be prevented because we need these veins for AV fistula creation later on. Now, what are the measures that we take for slowing the progression and reducing the complications? As I said, we target a blood pressure of around 120/80 or closer to that to prevent further damage to the kidneys by an uncontrolled hypertension. The HbA1c should be targeted to less than 8. Hgl2 inhibitors plus metformin in patients with CKD and type 2 diabetes. If target is not achieved, then GLP-1 receptor agonists are added. Then we look for complications of CKD, look for renal bone disease, look for anemia that can be taking place. We routinely patients, nowadays, of course, H1N1, sorry, not H1N1, the COVID vaccine is given to all patients who are on CKD and who are awaiting a transplant. When the patient is due for dialysis, or when we think that he is going to land up with renal replacement therapy, pneumococcal and hepatitis B vaccine is given for patients in stage 4 and stage 5. And hepatitis C screening is done because these are potential causes which would further worsen the kidney function. Now, where does dapagliflozin find its place in cardiorenal management with patients with type 2 diabetes? Dapagliflozin, empagliflozin, and canagliflozin have been, they have an established role in atherosclerotic coronary vascular disease. Dapagliflozin and empagliflozin have been tried for heart failure, particularly heart failure with reduced ejection fraction, and dapagliflozin alone has been found to be useful in DKD and chronic kidney disease. Now, there is always a debate between the original and the generic brands. So can generic brands be considered equivalent to the innovators? There is a lot of process that goes into development of any drug. Let us not go into the details of this because for short of time. So any drug for development of a new drug, it takes about 10 to 15 years going through all the preclinical trials, the clinical studies, and getting the approvals, and for trying the post marketing trials. And any drug before it comes to the market, it would probably cost the pharmaceutical company about $800 million US. Also, pharmaceutical equivalence may not always be bioequivalent, and bioequivalent may not be always equivalent to therapeutic equivalence. So a mere bioequivalent generic may not necessarily lead to the same therapeutic effect as the originator. I think I'll skip this. I think I'll skip this also for want of time. Now, the global prevalence and burden of CKD is substantial. Diverse etiologies include diabetes, hypertension, and glomerulonephritis are the main causes of CKD. Dapa Ckd is a landmark trial of more than 4,000 patients of CKD with or without diabetes, and it addresses a significant gap in therapeutic innovations, demonstrating a significant reduction in the risk of progression of kidney disease, CKD, cardiovascular, and renal death, almost about 40% reduction. It reduced Dapa Ckd trial demonstrates almost about 30% reduction in all-cause mortality and about 30% reduction in cardiovascular death or hospitalizations for heart failure. This builds on the evidence both from DECLARE and Dapa Ckd trial, further expand the cardiorenal and mortality benefits of dapagliflozin in patients with CKD. Thank you so much. I end my presentation here.
Thank you, sir. Here from our IMA Pune, Dr. B.L. Deshmukh, our president, will felicitate you. Kindly accept this.
Sir, this is bouquet for you.
Thank you so much.
Yes. And diary will be sending it.
Thank you,
sir.
Dr. Ambike. Just one question.
Sure.
For the benefit of all, that what is the Ejection cutoff you'll use Dapa, and suppose people are not doing Ejection, on serum creatinine level, should you think of giving Dapa?
Sunil, that is a very good question. All of us are used to using serum creatinine as the gold standard or as the marker for CKD. But a serum creatinine level, as I said, is very variable. It would vary with your body mass. It would vary with your age. So a serum creatinine of 1.5 for a frail lady of 40 kgs. So as I said, it would vary with sex also. So males would have a better eGFR than females. So as I was just giving an example, a CKD lady with a creatinine of 1.5 in a particular lab, that would be upper limit of normal. She is weighing only 40 kgs. She is 80 years of age, and she is a female patient. So that would probably put her into a stage 3 CKD, wherein if you go to calculate her eGFR by whatever standard, the Cockcroft-Gault formula or the MDRD formula is the one that we normally use. So it is better to go, not taking much of time of everyone, to calculate the eGFR rather than just going by EFR. So I would suggest more than eGFR, but if you have to take as a gold standard, more than 2.5 does mean a very bad worsening of kidney function, and up to a eGFR of about 25 mL per minute per 1.73 meter square, we have been using dapagliflozin.
Okay. Thank you, Dr. Ambike. We'll move on to the next two lectures. We have two ACE diabetologists, excellent academicians, and very good speakers, Dr. Godbole and Dr. Uday Phadke. We'll start with Dr. Godbole. He's going to talk to us on the glycemic effects of Dapa, and beyond that, can it prevent cardiorenal syndrome? Dr. Godbole, please. Dr. Godbole, are you there?
So can you see my slides?
Yes.
It's in the slide presentation mode.
No, sir, we can see only your desktop where we can see the documents.
Otherwise, you share at your end.
Sure, sure.
So thank you, Dr. Sunil, for the introduction. And I also thank the IMA Pune and all the office bearers and my colleagues in the IMA. I shall be briefly discussing, I'll just touch upon the glycemic effects of dapagliflozin and how we could extend the benefits of dapagliflozin to prevent cardiorenal outcomes. So please move ahead. So basically, dapagliflozin, of course, started off as an anti-diabetic drug. So the bottom line is it should reduce the HbA1c. And in the phase 3 development program of dapagliflozin, these were the results in the reduction of HbA1c when dapagliflozin was used as an add-on to metformin, for example, on a background of metformin plus sulfonylureas, in combination with once-a-week exenatide, which is a GLP-1 receptor agonist, on a background of metformin as an add-on to a combination of sitagliptin, metformin, and finally insulin. Now you can see the HbA1c reduction really depends on the baseline HbA1c. So if the HbA1c baseline is not very high, relatively speaking, say it's 7.9, then you can expect an A1c reduction of say 0.6, or you can hear up to 0.8. But if the baseline is like 9.3, somewhere around 9, especially if it is used in conjunction with a GLP-1 receptor agonist, you can even get an A1c reduction of up to 2%. And similarly, even on the background of insulin, as you can see, it's like close to 1%, which is a pretty robust reduction in the HbA1c. Next, please. In addition to the HbA1c reduction, what is important is the reduction in the body weight. And again, you have to go by the baseline body weight when you look at how much body weight reduces. This is again a part of the phase 3 development program. Again, the same sort of categories of background therapies. And you can see that all these patients were by and large heavy, anywhere from 86 to 91 kgs. And you could get a weight reduction of at the minimum of minus 1.6 in those patients who are already on insulin, which is not surprising because insulin itself causes weight gain. But if you look here, even on a background of metformin plus sulfonylurea, where some degree of weight gain would be expected with sulfonylurea, you still get a weight reduction of minus 2.7 relative to the placebo. And of course, if you have a combination of a dapagliflozin plus once-a-week exenatide, then the weight loss could be as high as in excess of minus 3.5 kgs. Next slide. Now, glucose control is fundamental, and we intuitively thought that if we control blood glucose well, automatically we would reduce the risk of macrovascular and microvascular complications. Unfortunately, that's not completely true. When we reduce the blood glucose control, what we know is that it definitely reduces the microvascular risk, but the verdict is still out on macrovascular complications. So for example, if you take these 4 trials, classic trials, the UK PDS, which was in treatment naive patients, type 2 diabetes, and then you had more chronic type 2 diabetes patients with a higher risk in the Accord, Advanced, and the Veterans trial. And you see whether the glucose control to a more intensive arm as compared to a less intensive arm, whether it reduces the risk of heart failure events. And unfortunately, in none of these trials, you can get a significant risk reduction for hospitalization for heart failure or in general for heart failure events. So just because you automatically control the blood glucose, it does not necessarily follow that you reduce the risk of macrovascular events and in particular heart failure events. Next slide. Now, this was a Danish trial, the Steno trial, where you had 80 patients in the conventional arm, 80 patients in the intensive arm, and they just didn't attempt to lower the A1C to 6.5, as you can see in the intensive arm, but they also attempted to strictly control the systolic and diastolic blood pressure, the various lipid parameters. There was addition of aspirin over here. They also added vitamin C and E supplements. So this was a sort of a holistic intensive management. And certainly to some extent, if you look at the risk of nephropathy in patients who are put on a conventional arm over here and the intensive arm, certainly there is an improvement in the risk of nephropathy. But what is important is this: there is a very significant residual risk. Even at the end of more than 13 years of follow-up, you still have a very significant residual risk of nephropathy, even in patients whom you have given intensive treatment and in a holistic manner. Next slide. So let's move on to the burden of cardiorenal disease in type 2 diabetes. Just move ahead. Yeah, these are the numbers of the prevalence of global prevalence of heart failure, the global prevalence of chronic kidney disease, and the global prevalence of diabetes. And these numbers, really, it's very difficult to make sense of such huge numbers. But what we know is that heart failure and chronic kidney disease form a vicious cycle, and one can cause and in fact worsen the other. We also know that 24% of patients with type 2 diabetes, 1/4 almost, would have heart failure as their first complication, where it could be preserved ejection fraction or reduced ejection fraction. And then nearly 60% of patients with type 2 diabetes would develop chronic kidney disease. So heart failure, chronic kidney disease, type 2 diabetes are often comorbid. Next. So how can we prevent cardiorenal outcomes? How can we first prevent kidney disease? We'll take kidney disease first, then we'll take heart failure. This was the broad design of the DECLARE-TIMI trial. That is the cardiovascular outcome trial with Dapagliflozin. And these patients who were recruited, by and large, resemble the patients which we are likely to see in our outpatient. So less than 60% of patients had multiple, at least 2 risk factors. So these would be patients, males at least 55 years and above, or females 60 years and above, with at least one of dyslipidemia, hypertension, or current smoking, or they would be patients in the secondary prevention cohort, those who had established atherosclerotic cardiovascular disease, which could be ischemic heart disease, peripheral artery disease, or cerebrovascular disease, and these form the remaining 40.6%. Now, if you look at the 3 CV outcome trials for Dapagliflozin, the DECLARE, the CANVAS for canagliflozin, and EMPA-REG for empagliflozin, you see the profile of the patients, and you realize immediately that the patients in the DECLARE-TIMI trial were less sick. So, for example, their eGFR was 86 compared to, say, the most sickest patients would be the EMPA-REG. They were all secondary prevention cohort. 74 was the eGFR, and you look at the proportion of patients with micro or macroalbuminuria, 30.9 with DECLARE-TIMI, and close to 40% with the EMPA-REG. So patients in the DECLARE trial had a better baseline function than the CV outcome trials with the other 2 Hgl2 inhibitors. Now, when you take a trial and you intervene, the sicker the patient, the better is the benefit. So if you start with patients who are less sick, by intuition, the benefit would be lesser because the patients themselves are less sick. But what happened? Next slide, please. Now, preserved renal function, the renal disease progression was a secondary endpoint in the DECLARE-TIMI trial. Remember, these patients, 50% of these patients had in fact normal renal function, and more than 80% were on a RAS blockade therapy. But in spite of that, even considering the relatively less sick profile of these patients, Dapagliflozin slowed the renal disease progression in these patients to the tune of 47% relative risk reduction. And by renal disease progression, it implies a composite of a sustained eGFR decrease beyond 40% to an eGFR of less than 60, end-stage kidney disease or renal death. So this is pretty impressive benefit for renal outcomes with patients with type 2 diabetes, but predominantly preserved renal function. Next slide. Now, if you look at the categorization of albuminuria, patients who were randomized to Dapagliflozin were more likely to improve in categories from the baseline. So from micro, they were more likely to shift to normal, from macro to either normal or micro, and so on. And they were less likely to deteriorate in an albuminuria category from the baseline, which means that less likely that a Dapa patient would move on from a normal or a micro category to a macro albuminuria category. So a favorable effect on albuminuria across baseline urinary albumin creatinine ratio, and these included patients with normal albumin excretion. Next slide. Let's move on to the second parameter for cardiorenal outcomes, that's hospitalization for heart failure. Next slide. Now, again, in the Dapa CV outcome trial, the declaratomy, the secondary endpoint was a composite of cardiovascular death and hospitalization for heart failure. Now, if you tease out the component of heart failure hospitalization, this is the result that you got. There was a 27% relative risk reduction for hospitalization for heart failure in the patients randomized to dapagliflozin compared to those on placebo. If you look at the baseline heart failure status of these patients in the declaratomy trial, 90% of them did not actually have baseline heart failure, only 10% had baseline heart failure. So again, I tell you, these are patients relatively less sicker, and yet you got this sort of a benefit both for the renal outcomes and for heart failure hospitalization. Next slide. When we talk of any drug, and in particular for Hgl2 inhibitors, we are always, concerned about safety profile. And thankfully, in the declaratomy trial, or in fact, any other trial that you take with Dapa-Ckd or Dapa-HF, the adverse events of interest, like volume depletion, compare that with the placebo, and you find that there is no negative signal, there's no red signal, whether you take fractures or amputations, as was seen with canagliflozin, whether you take diabetic ketoacidosis, though there's an increased relative risk, the absolute risk remains pretty low. What certainly is important and more prevalent is genital infections. You can see this over here, 0.9 and 0.1. So that's pretty significant. Urinary tract infections, contrary to popular perception, not more common in the Dapa arm compared to the placebo arm, and Fournier's gangrene, in fact, again, not statistically, or, there were hardly one event or so in the 3 trials combined. So very well established safety profile for dapagliflozin in type 2 diabetes, as well as in chronic kidney disease and heart failure with reduced ejection fraction. Next slide. So now this all reflects in the guidelines. And if you now look at the latest guidelines, the ADA 2022, following, the lifestyle modification, if you have a patient with a comorbidity in terms of high risk for atherosclerotic cardiovascular disease or an established atherosclerotic cardiovascular disease or heart failure or chronic kidney disease, then you ought to use either an SGLT2 inhibitor or a GLP-1 receptor agonist with proven benefit. Likewise, even if you want to minimize hypoglycemia, you want to minimize weight gain or in fact promote weight loss. And even then, considering the cost and the access, you would like to use SGLT2 inhibitors in general, maybe dapagliflozin in particular. Next slide. Yeah, so look at the comorbidities and look at the preference for weight gain. Next slide. Now, if you look at the 3 SGLT2 inhibitors in the CV outcome trials, the secondary endpoints were a reduction in the heart failure and CKD progression, and all 3 established SGLT2 inhibitors showed this sort of a reduction. Now, if you look at primary renal outcomes, so you have patients only with chronic kidney disease. The first trial to come was the canagliflozin. It also in only the diabetic patients, but in the Dapa, you had both diabetic and non-diabetic. EMPA doesn't have that sort of a data as of now. If you look at heart failure data, you have the Dapa-HF trial, you have the Emperor trial for empagliflozin. You don't have that sort of a data for canagliflozin. So actually, if you look at the green ticks, it's only the dapagliflozin which has green ticks in all these 3 categories, unlike Cana or EMPA, which have a red mark against one. The data is still awaited. Next slide. Again, if you look at various algorithms, say the ACE and the ACE guidelines, basically you look at the entry level HbA1c, and if it's less than 7.5, you can do with monotherapy, but you start at least 2 drugs if the entry level A1c is between 7.5 to 9. And in fact, beyond 9, it really depends on whether patient has symptoms. If no symptoms, triple oral agents. If symptoms, then insulin plus other agents. But if you're going to choose a monotherapy, again, you look at the comorbidities, which I already mentioned. And if such comorbidities are present, then you would start a GLP-1 receptor agonist or an SGLT2 inhibitor. They would necessarily be a part of therapy. Next slide. Now, this is the position statement from Europe. Basically all type 2 diabetic patients would be considered at a high CV risk. But amongst them, those with already a history of cardiovascular disease or multiple uncontrolled cardiovascular risk factors, a EGFR of less than 60, albuminuria of any degree, age less than 40 years at the diagnosis of diabetes would be considered as being at a very high CV risk. So for very high CV risk, now the expert recommendation is, if you have established atherosclerotic cardiovascular disease or multiple risk factors, you would consider an SGLT2 inhibitor or a GLP-1 receptor agonist alongside metformin rather than after metformin or stepwise. If it's heart failure, then you would then consider SGLT2 alongside rather than stepwise. But if it's CKD, again, it's the SGLT2 inhibitor, which would have preference over a GLP-1 receptor agonist. And a high CV risk, that's all the remaining type 2 diabetic patients, then you would have 3 options: SGLT2 inhibitor, GLP-1 receptor agonist, or DPP4 inhibitor. And then the other drug would be like a second line treatment. Next slide. So I think I'll end my talk here. I think it was pretty obvious that Dapagliflozin has a good data, not just on glycemic reduction, on weight reduction, but also on reduction of hospitalization for heart failure and reduction of hard renal endpoints. So you can certainly reduce the cardiorenal risk in patients with type 2 diabetes. In fact, you can even do that for heart failure, irrespective of diabetes, for kidney disease, irrespective of diabetes. And you can start using it in patients with, relatively good baseline renal function or relatively less risk for cardiovascular profile. Thank you so much for your kind attention and for your time. Thank you.
Thank you, Dr. Godbole. Excellent talk. Just 2 quick questions. Number one is the glycemic effects of SGLT2 in general. Have you ever seen hypoglycemia with these drugs? And is there any risk factor for hypoglycemia or no?
So per se, SGLT2 inhibitors themselves would not cause hypoglycemia because they reduce the glycemic threshold only up to 70 for glucose excretion in the urine. But if the patient is already on insulin or an insulin secretagogue like a sulfonylurea, then if you add an SGLT2 inhibitor, you're likely to get hypoglycemia because of the other drug, not because of the SGLT2 inhibitor. So it's wise to reduce the dose of such agents which themselves cause hypoglycemia.
How much insulin reduction you have seen when you have added SGLT2 overall in general average?
So it's a difficult question because it depends on the type of the patient profile. If it's a chronic patient on basal bolus therapy, maybe you might expect anywhere from 8 to 10 units on an average in most patients. But if it's a patient who is relatively less chronic in terms of number of years of diabetes, maybe if you're lucky, you can do without insulin if you add an SGLT2 inhibitor.
Thank you, Dr. Godbole. Over to IMA.
Yes, I request our President, Dr. B.L. Deshmukh, to felicitate Dr. Godbole, sir. Sir, this is a bouquet for you, and this is IMA Uparana. Thank you, sir. Thank you very much. Over to Dr. Sunil Sati, sir.
Thank you. We now move on to the last talk. We have none other than Dr. Uday Phadke. He's going to talk to us on practical tips and addressing clinical inertia with SGLT2. Over to you, Uday.
Thank you, Sunil. Allow me to just share my screen here. Okay. I hope I'm visible.
Yes, sir.
Thank you. One second, let me just bring up the pointer options. All right. So what I'm going to briefly talk today after that talk by Srirang is about the practical tips and addressing some of the clinical points in inertia when using SGLT2 inhibitors. We know that SGLT2 inhibitors are extremely useful. We have heard talks on their use in atherosclerotic cardiovascular disease, in patients with multiple risk factors, and also in patients with CKD. But the problem that we see across the world is that despite the evidence being shared with multiple physicians on various occasions, the use of SGLT2 is not optimal. Now, even though we know that these drugs are very useful, we still see that SGLT2s are kind of pushed over by sulfonylureas and gliptins, even in patients in whom they would be extremely useful. And these are some of the slides which just shows the databases across the different parts of the world, showing that even in patients with established ASCVD, Hgl2 inhibitors are less likely to be prescribed. And that is something which is not very good. Why really Hgl2 inhibitors? One of the most important facts is that apart from its different effects on the vascular endothelium, on the cardiac myocytes, one of the very interesting effect is on the glomerulus. Essentially what happens in diabetes is that there is a slight hyperactivity of the sodium glucose co-transporters, and therefore there is increased absorption of glucose and sodium across the descending limb of the loop of Henle, and because of which there is a decreased delivery of sodium to the distal tubule. Because of this, through what is called the tubulo-glomerular feedback, we see that the efferent arteriole gets vasoconstricted, but blood is still flowing into the glomerulus, but the efferent arteriole, which takes away the blood back from the glomerulus, is constricted, and therefore the overall effect is high intraglomerular pressure and glomerular hyperfiltration. Know that one of the important facts in progression of CKD is actually high intraglomerular pressure. Now, what happens when you're using the Hgl2 inhibitors is that it blocks the proximal glucose and sodium absorption, and therefore more sodium goes to the distal tubules, and this initiates what is called the tubulo-glomerular feedback mechanism. And now what this does is, instead of constricting the efferent arteriole, it constricts the efferent arteriole, and therefore less blood supply to the glomerulus, resulting in reduction in glomerular hyperfiltration. I think this is one of the most fundamental effects of Hgl2 inhibitors in the kidney. And by therefore using this particular drug, we are not only able to reduce the HbA1c, but there is also weight loss. There is also a significant reduction in systolic blood pressure of 5.1 millimeters of mercury. It may appear small, but even this reduction has a major impact on both CKD as well as atherosclerotic cardiovascular disease progression. Not only that, it reduces the urinary albumin-creatinine ratio, so it improves albuminuria by 33%. And this is on top of ACE or ARBs, not by itself alone. Even when standard of care drugs are used, it still causes further benefit. And what it does to the EGFR is that it stabilizes the EGFR from worsening. So in a normal case of CKD with diabetes, EGFR continues to worsen, but when SGLT2s are used, the EGFR tends to stabilize. Now, if you look at the overall effect of SGLT2s, we see that the effects are multifold. So for example, what I said was that in patients with diabetes, 50% of patients have CKD. And that is something which is very important. SGLT2 plays a major role there. Certainly, it's very, very beneficial. Now, 17 to 20% of patients with CKD also have heart failure. And this is something very important because this also increases the risk of mortality by 25 to 30%. And by reducing the progression of CKD and by also modulating heart failure, this important aspect is modified. We also know that 1 out of 3 patients with type 2 diabetes has cardiovascular disease. And amongst these patients, there is a 5-fold increased risk of heart failure. And when we're using SGLT2 inhibitors, there is a significant reduction in cardiovascular death and all-cause mortality. And the very important benefit, which was hitherto overlooked, was that it also has an effect on the fatty liver disease, on the non-alcoholic fatty liver disease, which may progress to NASH. And we know that this is now one of the important factors in causing long-term chronic liver disease and cirrhosis. Now, even the guidelines, if you see, these are multiple guidelines, but what essentially they now tell us is that even independent so the first used to be that if you have hyperglycemia with established ASCVD or heart failure or CKD, please use the SGLT2 inhibitors. But now what we are seeing is that even in patients who do not have established heart failure or ASCVD, but they are at a high risk, we can still use SGLT2 inhibitors. They are extremely useful. And the second important thing to note is that you can use this independent of glycemic control. So you can use them even as first-line drug. You can even replace metformin and use this as a single drug in patients with CKD, heart failure, and patients with high CV risk, apart from, of course, patients with established ASCVD. Similar things have been recommended by other guidelines like the AAC guideline and the American College of Endocrinology guidelines. So again, the important shift is that you can use them independent of glycemic control. This is something which is very important. And yet what do we see? They're used only in a small minority of patients. You can see here that after metformin, the choice of SGLT2 was made only in about 4.3% of patients with type 2 diabetes. And yet, DPP-4 inhibitors and sulfonylureas were still considered as the second-line drugs, even when these patients are at high risk of heart failure, CKD, or established cardiovascular disease also. There could be several reasons behind this. Physicians may fear the risk of urinary tract infection and genital tract infections, which is typically fungal. They've read about risk of amputation and decay. They've read about adverse event in elderly patients. They're also fearful of hypoglycemia, especially in non-diabetes patients, where again, now Dapagliflozin has a clear indication for reduction of heart failure, and people also fear volume depletion and AKIs. And I'm not saying that this fear is entirely unfounded, but let us look at what the safety data of Dapagliflozin says. If you look at overall treatment emergent side effects, you will see that actually the placebo had more side effects than the Dapagliflozin group. There are, of course, certain events which are more common in the Dapagliflozin group, and that is euglycemic diabetic ketoacidosis, but I'll come to this later. This is more a problem of selection of patients than seen in the majority of patients. So the majority of patients with type 2 diabetes do not get diabetic ketoacidosis because of SGLT2. Amputation, which has been looked at in multiple trials, as you can see here, no significant difference. Fractures, no significant difference. Acute kidney injury, in fact, you will see again, the placebo arm had more acute kidney injury. But here again, I'll tell you that you have to use this drug with caution, and I'll come to that slightly later. Again, this fear of volume depletion is not very true, no significant difference. Genital infection, of course, and urinary, the genital infection is one which is certainly more common in patients with Dapagliflozin group, and that is because of the mechanism of action. There was also a fear that a very fulminant disease called Fournier's gangrene can actually occur in diabetic patients, and it was linked to one group of SGLT1 drug out of the SGLT2 class of inhibitors, but it is now not seen at all in the Dapagliflozin arm, and therefore overall, if you see, it's an extremely safe drug to use. If you look at age-wise changes, the benefit of Dapagliflozin in heart failure or CV death, you will see that age does not matter. So no matter what age you use it, the effect is as beneficial without any major side effects. So even by the age categories, we don't really see major problems except those patients with very long-standing diabetes and orthostatic hypotension. Adding Dapagliflozin onto other antihypertensive agents, especially in patients whose blood pressure is very well controlled, can produce a small drop in systolic blood pressure, and one needs to be careful in reducing preemptively the dose of diuretics or other antihypertensive agents if necessary. This is something which is very important. If you look at the safety outcomes by diabetes status, again, you will see that treatment leading to treatment, dapagliflozin leading to treatment discontinuation is extremely uncommon. Okay, so it's not something which is very common. And all these other effects like acute kidney injury, fractures, amputation, volume depletion have never ever been seen. The only real effects could be really the genital mycosis. As far as acute kidney injury is concerned, in fact, we see that by using dapagliflozin judiciously, acute kidney injury actually is lesser in the dapagliflozin arm. Only if you use it in extremely unstable patients, where a lot of hemodynamic instability or volume instability is happening, or an admitted patients with surgery, or immediately post myocardial infarction, you could have a small risk of kidney injury. Otherwise, absolutely, I don't think we should be afraid of dapagliflozin used in these kinds of patients. So how do we use these Hgl2 inhibitors safely? For the control of genital and urinary tract infections, I think it's very important to counsel the patients that these kinds of infections can occur. We have to advise them about genital hygiene, wiping the private parts with clean swabs after urination, and that might go a very long way in preventing genital infections. Genital infections do occur. We can treat them with topical or oral treatments of antifungals, and most of the times you can continue Hgl2 treatments. Sometimes, of course, it is recurrent, and in which case we may not be able to use it. So urinary tract infections relatively are rare, but if they do occur, they are typically uncomplicated. That means they are usually cystitis and not typically complicated upper urinary tract infections like pyelonephritis or perinephric abscess. And standard antibiotics like the quinolones might give you a very good result. So by and large, the urinary infections are not a big problem. As far as lower limb amputations are concerned, as I showed you, in all trials, we have not seen any major risk. But of course, if a patient has very significant peripheral arterial disease, and more so if he's volume contracted, these are the patients who might land up into trouble. So in patients who have established atherosclerotic cardiovascular disease with peripheral arterial disease, always give them good advice about preventive foot care and tell them to inspect their foot daily. And at the earliest sign that something is occurring in the foot, like an ulceration, please be careful and stop the Hgl2. You have resolved the problem. So diabetic ketoacidosis will occur, as I said, only if we have chosen the drug wrongly. That means we are choosing to use Hgl2 inhibitors in patients who are extremely insulin deficient, who are very thin, catabolic, losing weight, or you think actually this patient needs insulin, very high fasting level, ketonuria already present, rapid weight loss, some degree of nausea, vomiting, abdominal pain. In such patients, please do not use Hgl2 inhibitors. And even if we do use them, please watch out for these signs of decay. And at the earliest sign, bring them back to your clinic, check their blood gas and sugars, and stop the Hgl2s. As far as bone fractures are concerned, again, as I said, there has been no increase in bone fractures in multiple trials, except one trial, which was seen in canvas. But again, I think these are not really linked to Hgl2 inhibitors. And then, of course, there are certain sick day rules for type 2 diabetes. So when patients are ill, they are admitted for dehydration or for some acute hemodynamic instability, say like cardiogenic shock or septic shock, you must stop what are called SADMANs. That means Hgl2 inhibitors, ACE, diuretics, metformin, ARBs, NSAIDs, and sulfonylureas. So remember this mnemonic of SADMANs. If you have an ill patient in ICU, you must exclude these SADMANs group of drugs. And then in a nutshell, if you look at the effect of dapagliflozin, you will see if you use them in patients with multiple risk factors, but no prior ASCVD, you will see that in such patients, you will get the best benefit of reduction of heart failure. That is something which is very important. You will also see renal benefit in this group of patients. Patients who have had prior myocardial infarction, you will see a reduction in MACE events. And in ACVD, but no prior MI, you will not get a reduction with Dapa in the MACE events, but you will clearly see important benefits in heart failure events and renal events. So no matter which group you use, these two things will always continue to occur. But in the people who have had prior MI, you will also see MACE benefit. So this is how we actually categorize how to use the SGLT2 inhibitors. So to conclude, we have already seen that guidelines recommend preferential use of SGLT2 in several groups like high risk of ASCVD, established ASCVD, heart failure, and renal patients. And very importantly, it is irrespective of glycemic control. SGLT2 usage should increase at early stage to provide meaningful cardiorenal benefits. There is no real risk of UTI. The risk of genital tract infections and decay is small and can be managed with right patient selection and counseling. Overall, the adverse events, even in elderly patients, are lesser than placebo. And there are no major hypoglycemic risk with dapagliflozin in non-diabetes heart failure and CKD patients. As Srirang said, if you're simultaneously using insulin or sulfonylureas, we need to stop them. So thank you very much for inviting me to this excellent symposium and giving me the time to share my thoughts.
Thank you, Dr. Uday, for an excellent talk as usual. I think a few questions for the audience. You know,
Yes.
suppose somebody is on SGL2 and now patients complain of burning micturition.
Yes.
So tell me, what is the threshold? What should I know that when should I stop it? You told most of the times you should not, but suppose somebody has burning micturition for 2-3 days. What is the advice I would give him if the patient is on SGL2?
So what we do typically is that we do a urine examination. If the urine examination does show evidence of infection, we give them a simple antibiotic like fluoroquinolones or even something like, Niftran or nalidixic acid. But if there is nothing in the urine, just a little burning, we just tell them to slightly increase the water intake a little bit and advise them about hygiene, because sometimes the burning is also because of terminal urethritis. At the tip of the urethral meatus, the sugar accumulates and causes a little irritation. So we tell them to use a clean water swab on the external urethral meatus after urination. If, however, they have fever with burning, with race counts, we do stop the SGLT2 inhibitors, treat the infection, also investigate that there is nothing that is occurring in the upper urinary tract. And once the thing has resolved, we can give another trial of SGLT2 inhibitors again. So that is how we do it.
So you will
three
give
groups,
a trial
no
to most
muscles.
patients?
Yes.
Most patients. What
Definitely.
about fungal? Suppose somebody has just fungal infection, what would you do? Give it a
Yes.
stop?
So with
or what
fungal
do you do?
infection, I will treat and stop temporarily. I will allow the fungal infection to be completely cured and give another trial with a good advice about genital hygiene. If it keeps recurring, of course, then we have to stop. Sometimes we have also seen that circumcision helps. So if we do want a SGLT2 inhibitor in place, they have reduced ejection fraction, they have ASCVD, we also sometimes advise circumcision, and then we are able to use SGLT2 inhibitors much better.
Can you decrease the dose of, say, Dapa to 5 and when something happens like this, or no? You don't think we should decrease?
No. I think we should stop and restart again once the event is over.
Okay. One more thing is about weight reduction. So much is spoken about weight reduction. Number one, really, what is the weight reduction you have seen? You told me that, you have mentioned it all depends upon your HbA1c, isn't it? The higher
Yes.
the HbA1c, more the weight reduction. So suppose somebody
Yes.
has obesity and the HbA1c is, say, 6.5 or 6.8. Chalo.
Yes.
So
Yes.
should I tell the patients that they not to expect weight reduction? What is it?
So I think weight reduction of up to 3 to 4 kilos is very uniformly seen with SGLT2 inhibitors. And some patients have extraordinary anecdotal weight loss of 8 kilos and 10 kilos, but that's uncommon. We generally see between 1 to 4 kilos with SGLT2 inhibitors. But they do definitely come back saying that their waist circumference has reduced because there is a predominantly a loss of the visceral fat rather than the overall weight in general.
Okay, and what about, is there any difference in the HGL2 or it is just a class effect for weight reduction? Because people are claiming that Dapagliflozin, which has come, in fact, reduces more weight than the others. Is it true, not true?
I don't think so. No, I don't think so. There is one small study which says that canagliflozin in a high dose, that is 300 milligrams, can cause a slightly better weight loss than 100 milligrams. But that's it. Amongst the classes, I think all of them cause equivalent amount of glycosuria and equivalent weight loss.
Now, just one question. With this linagliptin now going off patent, suddenly there's a surge of companies coming to you saying that, so the whole focus has now shifted from SGLT2 to gliptins. So what is your advice? I mean, what should we do? Or there's no comparison?
Gliptins have their own role in diabetes management. But when we are dealing with a patient who is complicated, as I said earlier, the categories of increased risk of heart failure, multiple risk factors for ASCVD, established heart failure, established CKD, and established ASCVD, you must use SGLT2, at least as one drug. And then if you require more drugs for control of diabetes, then of course you can use the gliptins, you can use sulfonylureas, metformin, all of them. But one of the drugs predominantly has to be SGLT2. There is no doubt about it.
Today in your practice now, has your sequence, suppose a new diabetic comes to you, 55-year-old, no CVD, but has your now line of thinking changed? People used to use glycomed, then sulfonylureas, all the routine one. So now, what is your prescription today?
So my prescription today, so my prescription today actually is divided into two main things. A group of patients who have risk factors. There are multiple risk factors. They go on to typically metformin plus SGLT2 inhibitors. And for those who are absolutely without any risk factors, relatively young, absolutely no risk factors, no heart failure, no CKD, no ASCVD, nothing, there you can continue to treat them like we used to do that in the past. So metformin and lifestyle first, followed by a second line agent, etc., etc. Again, there, if someone develops microalbuminuria, I would immediately shift this patient back onto a SGLT2 inhibitor. So it is more about a category of high-risk patient versus low-risk patients that we need to do this. So risk stratification right at the beginning is important. We cannot just keep on using drugs in the old standard format. That is given.
And finally, does your glycemic level, that means suppose somebody's sugar is high, So what is the threshold? That means when should I not use sulfonylureas? That means suppose your sugars are 250, 300 fasting PP, or even with high risk SGL2 and glycogen will be enough as far as glycemia is concerned, because that is also important, isn't it?
Yes. So now the thing is like this, that each drug has a threshold of reducing HbA1c. So since you asked this question, it's a very important and pertinent question. So let me tell you, let's say we have an obese patient who has never used lifestyle modification at all. I would say that if this person is really very careful, you can reduce HbA1c by even 2 or 2.5% from baseline without using a single drug. After lifestyle has been optimized, then...
Only with lifestyle?
Yes, absolutely. So we have gotten patients, yes, from 10, we have got them down to 6.5 if they really follow a good lifestyle and if they are early diabetics. And after lifestyle optimization, you take any drug and the average A1C reduction is about 1%. So after a good lifestyle, if your A1C is still 10, then obviously you cannot get away with one single drug like metformin or one single drug like SGLT2. You will have to have a combination of multiple drugs based on the duration of diabetes and the degree of A1C elevation.
Okay. The final question, which patients keep on asking us again and again. So many patients come to us, we do an angio, unstable angina, triple vessel disease, bypass or angioplasty required. When you ask them history of diabetes, no sir, it's only 1 year and perfectly controlled. So it's 1 year and
Yes.
perfectly controlled. Why did I get coronary artery disease? Why is it a risk factor? So what is the answer to that?
So the answer to that is that there is a correlation between degree of hyperglycemia and cardiovascular disease, but the correlation is not as strong as for, say, microangiopathy like retinopathy, neuropathy, and nephropathy. We also know that the onset of cardiovascular disease in type 2 diabetes often starts at least a decade before clinical overt type 2 diabetes has manifested. And that is because the pathogenesis of cardiovascular disease in these patients is also insulin resistance, hyperinsulinemia, dyslipidemia, hypertension, obesity, adipokines, chronic inflammation, which has started much before the sugars have risen. But the pathogenesis has already started. So the typical San Antonio heart watch clearly demonstrated that even biopsy studies on muscle arteries showed subclinical atherosclerosis 5 years to 10 years before actually diabetes began. So these are the patients who typically presented with CVD just 1 year after the. So their CVD may not have been purely hyperglycemia related, but the commonality is in the pathogenesis of both these disorders.
Okay.
Insulin resistance
final,
and the overall metabolic dysprofiling.
And final question, you have actually mentioned in your slide, suppose somebody is on Hgl2 as a routine for several months, years, and he has to go for a bypass or a major abdominal surgery, hernia, I don't know, a gallbladder.
Yes.
Should we omit Hgl2 in all patients?
Yes. So especially if you, so at least for 24 hours prior and 24 to 48 hours after surgery, we should avoid that. And not only Hgl2, but the group of drugs which I said, the SADMANs, all those groups will cause major risk of of acute kidney injury when used in hemodynamically unstable patients. So I would certainly use it. So for minor surgeries, I may not omit it.
Okay. But otherwise, it's an important message also because, suppose somebody is going for a perforation, I think you should omit Hgl2 well before, you operate.
Yes, yes.
So I think these are very important practical questions you have answered so well. So now I think we'll stop here. Any other questions from the audience? If they have, they can ask. Otherwise, over to you for the President's felicitation.
Yes. Thank you, sir. Sir, I'll request Dr. B.L. Deshmukh to felicitate you.
Sir, this is bouquet for
sir.
you.
Thank you, sir.
Thank you, sir. Yes, sir.
Thank you. I bow down to this.
Thank you.
Thank you. I think now we will, should we stop? We have asked questions. Any questions from the audience, finally, if they are?
They are from on severe asthma.
Yes.
Dr. Parthaval, but he has already left. I think Dr. Yenge is there. I think he is also not there. They are very simple questions. So from cardiology, I think, sir, you have asked so many questions.
Yeah, I think we have done the question session after each because most of the speakers said they have to leave. So I think it was better to finish the question answer session right away.
Yes,
so I think it was an important symposium, and I must thank IMA for having these symposiums. I think we should have more practical symposia for the benefit of all of us. And I really thank them to keep this session. And I'm sure our audience, whoever have attended, will be benefited by this session on asthma and the Dapa sessions.
Sir, my sincere thanks to all eminent faculties. It was a great academic feast in spite of your tight, busy schedule for giving us your valuable time. Thank you once again. Thank you, Dr. Sunil Sate, sir, for moderating this session with important, tricky questions. So I think all the cardiology questions part has been asked. And I thank you all delegates and thank you DigiShield for technical support, especially the Dipen Mehta sir and his team. And thank you AstraZeneca team for academic grant for this webinar. So thank you very much. I think with our
Thank you all.
Yes, thank you, sir. Thank you very much. Yes, so it was a nice presentation. We are getting many remarks, and it was very nice presentation. The people are just yeah. Thanks to IMA, thanks to Dr. Sunil Sate.
Thank you. Thanks, IMA, and thanks, Sunil Sate. Thank
Yes.
you very much.
Yes, yes.
Thank you.
Piyush?
Yes, ma'am.
Yes, you can